Sejam todos bem-vindos. Tem início a cerimônia de abertura da 17ª Reunião Nacional de Pesquisa em Malária. Solicitamos aos presentes que ocupem os seus lugares.
Meeting about malaria. We ask you to have your phones silent mode, and the videos we're going to film.
Recording in progress.
And it will be available on YouTube. We have aggregated the research team in control of malaria. Its first edition occurred in 1986 in Rio de Janeiro, and now it goes back to the north of the country. This Belen's edition occurs in a strategic moment, understanding that in 2025, Belém will be the host for the Convention on Climate Change, COP30, which aims to promote Brazil's agenda and other countries regarding environmental issues. In 2023, Belém was the host also for the meeting to combat malaria, and we have as an aim the elimination of malaria in Brazil until 2035. So on November 6th, we have Malaria's Day in the Americas, so it's important. It's an important day for us in Latin America, and we have to attract attention from different sectors, especially because we highlight the responsibility of the Pan-Amazonian countries that have the focus on malaria as a disease, and as an endemic disease that happens in Brazil. And for this moment, to compose this roundtable, this opening ceremony, we summon the director of the Ministry of Environment, Alda Maria Cruz, the Superintendent of the Ministry of Health, Deucimar de Souza Viana, the Director of Evandro Chagas Institute, Lívia Carício, President of the 17th RNPM, Giselle Rachid Viana, she works at the Evandro Chagas Institute, and the Honorable President of this meeting and researcher of Oswaldo Cruz Institution, Cláudio Tadeu Daniel-Ribeiro. Welcome for its welcoming remarks. Now we ask for the President and researcher of Evandro Chagas Institute, Giselle Rachid. Good morning, everyone. Again, it's with a great honor and joy that we want to welcome all the participants of this edition, which is the 17th edition of the research meeting about malaria in our beautiful city, Belém do Pará. As we have commented before, today's November 6th is the day established by the PAHOs as the day to combat malaria in the Americas. And we are here today not only as researchers, professors, and health professionals, but especially as partners in the global fight uh, about this disease that unfortunately causes lots of deaths. And this is a traditional event, a national event, and more specifically about this topic, gathering the community involved in the control of endemics. Its first edition occurred in 1986 in Rio de Janeiro, and at that moment it was idealized by our honorable president, Dr. Cláudio Tadeu Daniel-Ribeiro, and we have this privilege to have him here, returning to one of the states of the legal Amazon. Since then, the malaria meeting has been in many places, such as São Paulo, Brasília, Amazonas, Pará. In this edition, we had this meeting 3 times happening here, and also Minas Gerais, Pernambuco, and lots of the presidents of these meetings are here today as guests and speakers in the 17th meeting. Pay attention along these days pay attention to the presidents of all the editions that we have had already of this event. The topic of this event, Malaria in the Americas, Perspectives towards the Elimination, taking a look at from it from a global perspective. So in general lines, this edition has as main objectives to contribute for the integration of research and control actions, and also debate actions towards the elimination of malaria in Brazil, taking into consideration the epidemiological scenarios, and this goes through lessons learned in other parts of the country and other countries, and through the learning, the collective learning and scientific research, we can find viable actions to reduce the number of cases of malaria and also try to reach the goals around this topic. And on this side, we try to strengthen the cooperative networks, which is essential so that we can advance toward these goals. And in the next few days, we will have an intense job exchanging experiences and mutual learning. So let's take advantage of this moment, trying to pursue innovative and equal solutions for this problem, trying to have the health of our communities on the first place. I would like to finish this speech thanking the organizers, the institutions that organized this event. Evandro Chagas Institute, FIOCRUZ, Ministry of Health, and supporters, CESUPA, CNPq, and all the professionals that made this event possible, our guests, speakers, researchers, and all health professionals. Thank you for being here today with us and for contributing to this discussion that is so fundamental in the global health perspective. And we hope that this can happen in a productive way during this week. Let us have a productive event and an inspiring event above all. Thank you for your presence, and let's share experiences during this week. Thank you and good morning. At this moment, we will listen to the Honorable President and the researcher of Evandro Chagas of Oswaldo Cruz Institute, Cláudio Ribeiro. Good morning, everyone. As an Honorable President, I would like to greet you all we want to thank for the presence of the speakers and everyone. So we have some short tasks. First, I can congratulate Evandro Chagas Institute and Giselle for the organization of this event in Belém for the second time. She has already said that it was created in 1986, so we have had different organizers. We have more organizers than events. So thanks to it, we got here to the 17th edition. So thank you, Giselle, also for my nomination as an honorable president of this event. I'm very grateful for it because I'm very connected to the city of Belém, and I have already worked here for a long time, and sometimes we could get the products to study malaria in Belém, better in Belém than in other places. So we created this event in 1986 as an international symposium with guests from abroad and from Brazil. And I was happy because of two surprises, two very pleasant surprises that happened in the past. The first one is that I got to this event on the first day, and I realized that it was alive, and then I could go to other places, and it was already there. So, and today she can see that she can go have some breakfast later on, and the event will go on. And the second surprise was the amount of students that we had in the event. So it happens because this event occurs in different places, in different cities, and we have different groups of students that come from different parts of the country. And this is a great pleasure, especially for me, Giselle. There's this pleasure to see how this event is alive, and it is even greater when this event is extrapolated. So we have I suggested him to combine the meetings of NIH and the other research institutes. So it's important because we can collaborate with, can interact with colleagues from different places of the world. And the main motivation is that when I came back from my doctor's degree, I went to a meeting continuously, which was a research meeting about basic research, actually. And I guess it was about Chagas disease, and it was the best event. But we were not talking about malaria. We were not discussing it, so we tried to create it. And so my colleague went out to discuss. There was a discussion between the organizers, among the organizers, to create this meeting. And at last, I would like to say that this event has an important participation, a great support from the Ministry of Health. And I am convinced that it has been an exemplar institution to promote synergies between research and politics. So the Ministry of Health tries to understand what the research has been saying about this. So this discussion has been promoted by this institution. So all of our colleagues have embraced this cause. And there's also another event that happens. And they have also this role to integrate research and teaching. So I am very thrilled to have you all here in our 17th meeting, national meeting, in this beautiful city called Belém do Pará. Thank you very much. So now with the word, Director of Evandro Chagas Institute, Lívia. Good morning, everyone. All the people present here. Alda is just coming in, and there's the importance, I'd like to greet Dr. Viana, Giselle, Dr. Cláudio, and Alda. Please be here with us. Alda, the Ministry of Health has really had a great job. It's made a great job regarding research devoted to the best strategies and experiences to apply on public health. Evandro Chagas Institute, it is an example of it. It is an institution that is connected directly to the surveillance of the environment and health. And it's been 28 years that it has embraced studies about diseases that happen in the Amazon, and our focus is on infectious diseases, and malaria has always been one of the main problems in public health. And Evandro Chagas Institute has been working on the discoveries and possibilities of how we could find solutions to improve the lives of the people that live here. And at this moment, with this meeting, I have to thank and congratulate this research group of Evandro Chagas Institute that works with malaria. In the name of Giselle and Dr. Marinete Póvoa, that has been building a strong group inside the institution and unites everyone towards tackling malaria. I really hope that this meeting is extremely fruitful, and I hope that everyone that is here, whether it's health professionals or from different teaching institutions, I hope that we are here discussing these strategies in a very special moment that we have been living in our country, facing climate change. We know that in our regions, the differences in the environment have an enormous impact, especially on vectorial diseases. So we have a great challenge, but these meetings are very important so that we can pursue the best solution. So I hope that we have a productive week. We begin with a symposium, which was extremely important, and 2 days ago we discussed extremely important topics as well. And so we continue with this event, and this national meeting regarding malaria is actually important. I guess Alda is going to talk about it, and we have structured a work inside the Ministry of Health to reach some goals in these 4 years. So I won't say anything else. Welcome to Belém do Pará. Enjoy the city, enjoy this week, and I hope that this event is extremely relevant regarding these discussions and the promotion of knowledge. Thank you very much all. Good morning. Registering the presence and composing our welcoming remarks, the Director of Transmissible Disease of the Surveillance Secretary of the State of Pará, Alda Maria Cruz, for her welcoming remarks, the Superintendent of Health in the State of Pará, Viana. Good morning, everyone. Welcome to the capital of our state of Pará. As Livia said, we are going to host COP30 next year. I'd like to greet Alda and Giselle and Dr. Carlos. And ladies and gentlemen, on April 25th, we have a day for malaria awareness in the world, in the state of Pará specifically. Dr. Alda, we have some cities that are epicenters of malaria: Jacareacanga, Itaituba, Breves, Anajás, and Bagre. From these five cities, we have 3 of them are in Marajó. So Anajás is in the center of Marajó's island, and it has contact with other cities in the region. So we have had actions in these cities. We have distributed some nets, and malaria specifically has reached important rural zones, especially places where we have mining activities. And since 2023, in 2023 we had an emergency situation in the Yanomami land, and we had several actions in the past in that place. So the Secretary of Health has developed some actions together with some cities, distributing 1,500 nets in the cities. So there was a program that was developed together with the city of Breves and Curralinho. And we had the participation of COSEMI, and the president of COSEMI is from Breves. So I would like to I'd like to talk about this Malaria Zero program that was developed in the city of Breves and Curralinho. So ladies and gentlemen, welcome to the 17th National Meeting of Research in Malaria. Thank you very much. For her welcoming remarks, Director of the Transmissible Diseases of the Secretary of Surveillance, Alda Maria da Cruz. Good morning, everyone present here that accompany us, and online as well. It's with great joy that I am here, back here in Belém in a malaria meeting. So I bring here a hug from our secretary, Lívia Maciel. She was here last year in Belém in the 20th meeting of the malaria program. And I'd like to greet the participants of this table, this round table of this opening ceremony. My colleague Lívia, Viana, Giselle, dear Giselle, and together with my dear Cláudio. And I apologize because of my delay. And the worst thing about it, well, I didn't listen to Cláudio Ribeiro speaking, and that is a problem for me. Every time I am in a malaria meeting, I remember Cláudio, our master immunologist. We were quite young, right? And I have to talk about the importance of having you today, coordinating this event here in Belém. You that recently was honored with a medal, Virginia Choj. We know that this is important, and it shows the importance that you have in the education scenario landscape. It is not different with the malaria's events. These events have happened for a long time, and it's something that is very honorable. This shows Cláudio's role in education. So I'd like to highlight this condecoration, this honor, and we at FIOCRUZ, we could have you as one of our researchers, one of the few in the gallery like that. And I'm talking about Cláudio because I'm talking about this meeting, and for me it is very significant. And he used to teach immunology, and he made it an analogy with French fries. And so this remained in our head.
Não só técnicas, mas também nas questões científicas e
the management with the malaria and all the measures that are necessary and being conducted on the leadership of Alexander Vargas, which was replaced in the coordination of in a lot of a team that is very eager, and integration is very important. And between service and research, that's a characteristic of a SVSA, because it's an academic institution. When we bring EEC as under the SVSA umbrella, I think it strengthens this role of research. So it's very significant that this meeting is being held here when we will have COP30. When we get to the city, we still feel what Círio de Nazaré. And this table is composed by, we are in the same color palette, right? I'm sorry, my friends, But of course, I had to make this little joke. So I wish you a great event. So we have reflections. So we have ways to eliminate malaria with this big task that we have uh, after the malaria elimination. Ladies and gentlemen, we close our welcome table and we invite the people who composed the dispositive for the official registration. Please, a round of applause. Please take your seats. Thank you. And this is how we begin the conference, Malaria in the Americas, Challenges and Perspectives for the Elimination. We now invite researcher emerita from Institute Evandro Chagas, Marinete Chagas, for the work. Good morning, everyone. It is with great joy and great satisfaction that we begin our scientific part. I have this very good position. An old partner in the field work with malaria, and we don't see each other since 2019, so this is a fabulous encounter. And Dr. Montoya, a doctor in tropical medicine, since 2002, he is in charge of the malaria control and transmissible diseases in Brazil, Colombia, and Ecuador. Since August 2016, Dr. Montoya became the regional assistant for malaria in Washington. And today he will greet us with the theme Malaria in the Americas, Challenges and Perspectives for the Elimination. Welcome. Thank you, Marinete. For me, it's a great pleasure to be here and to participate in this research meeting. It's impressive how old this meeting is. I was just talking to Cláudio, as for a few times you in Brazil think this is normal, but this is just something that is exceptional. We have to value a lot. It's a great relevance for us in America. I'm very glad to be participating. When Giselle invited me, for me, it's always a pleasure to participate in activities in Brazil. It's always a great pleasure. I'm very glad to be here. As Giselle already said, today is a day that in Americas we celebrate Malaria Days in America. This is another reason to be glad in the possibility of celebrating this day. And this year, we are promoting the theme to expand the access to the diagnosis and treatment for all. I will also talk about the importance of this theme in my presentation. Firstly, before we talk concretely about the challenges and expectations of the elimination of malarias in America, we should look into the situation in the region. We closed the year of 2023 with more than 500,000 cases of malaria. This is 5% adding regarding the data that were reported by the countries in 2022, and something that is very close to the number of cases in 2015, which is the baseline. So you can see here in this graph that we are far from the goal that was approximately 120,000 cases for 2025. So it's a huge challenge, but possible. The message I am sending should be optimistic because I believe it is possible. The data of 2023 are here. The countries report to us. Brazil. I'd like to highlight the amazing policy that Brazil has to share the data publicly. This is an example, and the other countries, they also share. This is the 2023 data. I think in 1 week or 2 weeks, the World Health Organization will be publishing the data of the world. We also had adding in Colombia and Brazil and Panama, and associated to the migration of people. Also in Guyana, also. And we have good news also. As you can see in the lower part of this table, in Suriname, for 3 consecutive years without transmission, without malaria transmission. This is something historical, and it's got a huge importance. This is the first time in history with an Amazonian country registering 0 transmission for 3 years, and this puts this country in the situation of requesting the accreditation by the WMO. I think in this meeting we will have Dr. Matelis participating, and she was part of the success of Suriname and other countries with very few malaria, like Mexico. It reached 46 cases in 2023. This is amazing for the size of Mexico, even with a very big number. Costa Rica, Dominican Republic focused in 2 situations that are very favorable for the elimination. And these are the countries that were accredited in the last years, and these are the countries that we mentioned to be closer to stop transmission. It's a very big number, particularly in Americas, but this is the problem of the high rates that we have in South America, in Brazil, in Colombia, Venezuela, and also Guyana and Peru. But Brazil, Colombia, and Venezuela have this big part of the cases, and we must impact here. And in the countrysides, we also have to impact high transmission. In terms of age, we have 2 different standards, and it's important for kids in other countries, but malaria is more occupational in other countries, and malaria, distribution of malaria in the countries focused in some municipalities that focused 33% of the cases. So it doesn't happen to dengue, it doesn't happen to other diseases. This is in terms of the doability of elimination, this high concentration of malaria in some municipalities, for example, in the municipalities in the region that can concentrate the biggest number of cases of malaria. And in the P. falciparum case, the possibility of eliminating that we are considering a priority for the Americas, the idea of the speeding of elimination of the P. falciparum. Many countries are very close to Central America, like Honduras, Nicaragua, have very low numbers of malaria. And I think in a while, Central America will eliminate malaria. And I believe that for the South Americas, it's a priority. And I will talk about this a little bit ahead, about the distribution of the cases of P. falciparum by municipalities. Colombia, we have the Pacific region, the Colombian Pacific, Brazil, and Venezuela. And also, we'll talk about the challenges which have three categories that we highlight: the socioeconomical, the biological, and the challenges regarding the interventions and the services. In the socioeconomical context, you have the movement of people, the occupation of the space that you know better, the main determinant of malaria in the region, which determined the cases of Venezuela 4 years, and the main determinant in Colombia, in Suriname, and the French Guiana, and in all of municipalities in Brazil. So we are the price of the gold is rising, and this is going to be a huge challenge for the elimination of malaria in the Amazon. We need some changes approaching this theme. We can't eliminate malaria in the Amazon without being approximated to these problems. We will talk a lot about the reinsurgences, and in the services, I'd like to highlight the big possibility that we have to influence the barriers for the treatment in the municipalities of Brazil, Colombia, and Venezuela, the populations to have access to some interventions that should be public. So illegal mining, we have, besides the implications in terms of the rising of cases, we also have the risk of resistance in the nuclei of mining, where you have the circulation of malaria and also the therapy. This is a perfect scenario for the selection. And we talk about migration. As you can see, this graph from Mexico, this line in red are the imported cases. Remember, I talked about this peak in 2023 when Mexico reported a history of 300. This peak, Mexico reported the lowest transmission, which was 46, which says it's possible, even having a big pressure. And this is associated to the migration. So people with malaria have this transit between Panama and Mexico, and then we have the disease in Mexico. We have some very important situations happening in Panama where we are characterizing a transmission situation, and this sparked by environmental modifications, not precisely the migrant malaria, but malaria for the populations. And when you talk about the biological field, Brazil is a pioneer when you talk about this. I won't talk a lot about this because the audience is aware about this data, and maybe you are not too familiar with the reports of uh, re reoccurrences, and it's very useful for the monitoring which Brazil does um, in similar ways, which allows to observe some changes in the proportions of cases that are reoccurring. Uh, when you associate more cases and more recurrences and the mixture of reinfections, and it's more interesting when you look into concrete situations in a country in the South Americas, which has an exercise to identify in the data bank the repeated cases, and this is impressive. Until up to 45% repeated cases in municipalities. And that means the problem, even if it's a mixture of reinfections and reappearances in the repeated cases that we have, is a very big challenge. And we must go far in the studies because the clinical data in the studies of the Americas controlling the administration of treatments and supervised treatment always showed a percentage that is very high of reoccurrences, even in situations of treatment directly observed. The rates are impressive of 24% reoccurrences up to the last study that was made comparing the Primakin double dose. So the approaches, I have three options here. I don't see others to raise the doses, the unique dose to improve the effectiveness of as what Brazil is doing, or repeat the treatment. The WMO is working in this recommended process, phenoquine, which is not recommended to Brazil yet. Brazil is a pioneer and also contributed a lot for this. For this year, we had the recommendation done, phenoquine. Brazil is already doing this, but we also have other things. We have new recommendations of WMO for the raising of the doses of primaquine, and I think these things are what we have to add together for different contexts where it's possible to have a scheme where it's going to be very hard to add this in this stage, and etc. We have a big field of research for the operations and to implement all this. About the resistance, this is for Africa, and this is something that is happening now.
In the global community of malaria, it's a main concern, the promotion of resistance, partial resistance in Africa. It's 4 countries already reporting the partial resistance to penicillin and the preference for the mutation. And besides that, and the treatment in parasitological testing, and it has been increasing proportionally in the country. So the message for us in the Americas is that we have to stop this soon. And I was talking to Dr. Rafael. We have to eliminate it. We cannot have this happening in America. We have mutations already in Guyana, in that place where we have conversion of monotherapies and illegal drugs and mining. We have to eliminate the perfosiporus before we have resistance. If we have resistance in the Americas, it's going to be very difficult. This is something for us to do now. So it's a priority, and I hope that this is a priority in the project of elimination of malaria also in Brazil, but we have to really make these changes. So the risk is there, and we have to eliminate the perciferous. And we have with the other interventions, I want to emphasize this part here because it's on the hands of the Ministry of Health and our interventions, the barriers that we have for treatment and health services and health units in endemic areas. So I cannot believe we don't have a health unit in an endemic area, a place that has no diagnostics for malaria. It's been 25 years that we have rapid tests for malaria demonstrated already. They are not perfect, but it is public health. We have to balance things, but it's unbelievable. We have many other situations. I will not show them now. It has got to do with barriers in diagnostics. In a community, people have to walk for 1 hour to get a diagnosis. And 1 hour by river, for example, in the rivers in the Amazon. 1 hour seems close, but it's not close. It's a reason to delay things. It's simple as that. This barrier is there all the time. I have already talked about health units that don't have rapid tests. That's unbelievable. I'm not speaking only about Brazil. I'm talking about the region. We have places in which we have a rate of transmission of 40%. That's unbelievable. We're talking about malaria. So the barriers of participation of the community is there. We are not working with the communities. We have legal restrictions sometimes. For communities to participate of this movement. And there are volunteers for it. We don't have volunteers for it, so we have also a barrier for the precocious, for the early treatment. And there are countries that are going to lose the anti-malarians. That's impossible to think about that. If you want to amplify the treatment, we should have decisions, and I guess we have a space here also for operational research. So what are the perspectives? I guess we have to think about what can we do to do things differently. And that's what we have been doing since 1992, which was the Global Malaria Control Strategy. So if you take a look at this curve, there was a very important reduction in the Americans, and in absolute numbers, this happened a lot because of Brazil. So these are numbers of this fall of transmissions in Brazil in 2005, 2004. But we have to do things differently. So before we were dealing with control, and now we have to do operational changes. We have to understand that malaria has to be eliminated in micro territories. So territorially, we have to eliminate things gradually. So we have to have operational goals for elimination, and it's much lower. In cities, we have to expand, amplify, I don't know what's another important word. We have to amplify diagnostics and treatment. We have also to reduce, to decrease the reactive interventions, especially chemical interventions. So it's a very important topic for research. We are showing a lot of evidences. We have to amplify coverage, vectorial control. For example, bad nets, we have to expand. It's not the same idea of diagnostics and treatment. The idea for diagnostics and control, diagnostics and treatment is not the same of control. So we have to include in all of the cities this topic of diagnostics and treatment. So all of the health units have to be inside the communities. 1 hour to get to the health units is a long time. So the anti-malarial drugs have to be a public asset. It's a public asset, and only when this happens, this is in the communities that are affected. We have to protect the microscopics. There are few institutions such as Evandro Chagas Institute, FIOCRUZ, PAHO. Nobody's going to deal with this microscopy anymore. So we have to use this technology to reach millions of people. So we had this meeting 1 month ago in Colombia, and we talked about expanding these 2 communities, and we talked about these changes that have got to happen. We need a permanent diagnostics. Where we have transmission, we have to have people being diagnosed. So the medication also has to be there where we have transmission. The supervision in an area has also to be innovated, but we have different technologies to do it. We have to understand the territorial codes. That's fundamental to have this to make this in a sustainable way. And the microepidemiology, there's no other way to do things differently. To eliminate, we have to have people thinking and making decisions on the field. And for this, we need changes in a more national scope. We have to make new alliances. We need to improve technical norms, technical regulations. We have to use rapid tests in the Americas. It's very low. The use of it is very low in Americas. So in green, you have the use of rapid tests. So it's very low usage, and we have positive cases in countries such as in Brazil. Brazil has 80%. Only 13% of cases being diagnosed with rapid tests. So this can be improved a lot. I'm sorry. The idea of micro-territories free of malaria. So we have to eliminate micro-territories, and for this, we have to organize zoning and teams. This is a fundamental aspect for the elimination, and also a change in the operation and in the introduction of the concept of verification of subnational verification of elimination. And this can be made in a very stimulant manner. We have been discussing this with the Ministry of Health, and these are reports that PAHO has been creating. Amplification of access to diagnostics and treatment, interventions on chemical preventions. This is a very important topic for research. In the pink tables, the pink cells, there is a very low certainty. And so here we are discussing administration of drugs, massive administration of drugs. We have 3 different interventions, and we have really low evidence on mass strategies, targeted strategies, and reactive strategies. So the level of recommendation is a conditional recommendation. So we have a great area for research. And the elimination of perfluoroalkyls is a fundamental topic. So we have many gaps in knowledge, and we need to do it. These are the documents we have been working on. And finally, this was another conclusion that we have had with the countries. The elimination is not possible only as an intervention made by the ministries. That's not like that. The elimination has to be precise with a real alliance with the affected communities and stakeholders involved. Communities that are on the surroundings of mining activities and different levels of organization. I think it's impossible. It's impossible to do things without the participation of the communities affected. So we are part of a program of elimination of 30 diseases, not only malaria. And there is a particular topic about these diseases is that they shouldn't exist. It's hard to defend this here because a lot of them have low charges. But what is easy to understand is that it shouldn't exist. No one at this time should be infected with these diseases. So this is a priority because of it. It's not a matter of age. It's because it's possible. Another thing that is important is that we have chemical preventions. We have evidence. So this is a priority of the director of PAHO, Dr. Barbosa, and we include here malaria. So thank you very much. I'd like to highlight the importance of today to be celebrating this Day of Malaria in Americas, and I would like to invite you to not only be here discussing this today, but you should participate of a webinar we will be having on December 15th, and we can discuss this later on. So thank you very much, Giselle, President of this meeting. I'm very happy to be here, and it's a unique opportunity for me to be talking about this today. Thank you again. Dr. Roberto, thank you very much for the brilliant speech, for the analysis that you made, and for leaving us with reflections and thoughts, especially us that have come a long way. We have colleagues here since the 90s that have studied and worked since the 90s. We are in this path in Brazil. We recognize, we acknowledge mistakes and things that we made right, and we have here a greater analysis. We could see the contribution of Brazil in reducing the cases of malaria in Brazil, which is very important, and this gives us strength to continue believing that we are capable, that we have a group that is capable of working in all of those areas as you have discussed. So we have to continue on this journey. taking a look at new possibilities and thinking about what is our role in it. The conference does not predict questions to be made, so I would like to thank you for your presence and for your contributions, and continue to think what we can do in the Americas. Thank you very much. So let's maintain, please, the timetable during the day. So thank you, Marinete Martins Póvoa, Roberto Montoya. So we'll begin now the mini conference, Elimination of Malaria in Brazil. Where are we? To preside the works, we invite the researcher on the coordination of elimination of malaria, of the transmissible diseases of the surveillance secretary, Alexander Vargas. Alexander Vargas, sorry. Good morning, everyone. I would like to begin thanking you for the opportunity and I'd like to congratulate you for this event. We know about the difficulties and obstacles we can face. We will have a lecture today with Dr. Alda. The lecture is Elimination of Malaria. Where are we? So Dr. Alda is graduated and is a doctor. She has master's and doctor's degree in tropical medicine by FIOCRUZ. She's a specialist in infectious diseases, and she's an associate professor of UERJ, which is the University of Rio de Janeiro. She's a member of the Medicine Academy of Rio de Janeiro. She works in pathogens of leishmaniasis and HIV and vaccination of leishmaniasis. She is my boss. And Dr. Alder, please.
Thank you, Alex. It's a great pleasure to work together. You know that he jokes about this when he talks about this. This is a nickname we use. Well, here we have this task to talk about the elimination of malaria in Brazil, where we are. So, in the coordination for the elimination of malaria, we had some reflections made, and it was very important to have this theme. It's always a moment for the group to reflect, and the presentation I will have is a presentation that was elaborated by SEMA. So thank you for all the technicians for the elaboration of the material. Well, malaria talks about the elimination for a while, but Brazil today has the healthier Brazil Unite to Care that it was created inside SSA. We had as a goal the elimination of the tuberculosis as a public health issue, and due to the social background of our minister, when she analyzed the demand, she suggested to add the elimination of diseases that are determined socially, and she suggested the inclusion of diseases that had as a base the social issues. So I think this was a very important change in this elimination perspective, because we are talking about the elimination of this or that disease, but a lot of diseases that occur by things that are common and determinant or outside health. So I think this is the important element. We are treating this program. This is not a program that cares for the health issues. It integrates other components that impact, limit, or in some situations, they stop the elimination of diseases. I'd like to remind you of some concepts that are important, and we understand that a lot of people confused malaria itself in the past used the eradication terminology. We are not talking about eradication. I think this is very clear for this public, but people have been confused. So what we have eradicated is the uh, this terminology is not used. What we eliminated was the smallpox. So when general goals we've measured with or the elimination of the transmission, which is the reduction for zero incidence and the minimum risk of introduction. And in this context, malaria is inserted. When we analyze the timeline of the control activities and elimination, we can see that since 2000, with the plan of intensification of control of malaria in the legal Amazon, we go through many steps. In 2015, the plan of elimination for Plasmodium that Cassiopeteca is waiting to intervene. So we had the national control, the national program for control and prevention of malaria, and the disease is transmitted by Aedes, and we have followed with the national program of control of malaria. We already have this request to change, so we start calling the elimination in this context, and this talking it with the national plan of the malaria elimination, with the creation of the coordination of malaria elimination last year, as I have commented before, and also the inclusion of malaria in the Health Brazil program, which I'm going to mention to you later. This is a program that focuses on a lot of diseases like the Chagas disease, geomycosis, trachomas, and filariasis, and a group of diseases that have vertical transmission, the Chagas disease, hepatitis, HIV, HTLV, and syphilis. So these are diseases that are inside the scope of the World Health Organization, with the elimination as a problem of public health up to 2030. And thinking about operational goals, not about the elimination of transmission, we have uh, all the hepatitis and HIV, all of them with specific goals that could be measured and that we can monitor for the validation. A big worry that we have, and I am showing you this graph. This figure is well known by you to show the challenges that we have in the elimination. I learned that we call the this chain graph, because every time we have a reduction of malaria graph, the policies are discontinued, and then we go back to having more cases. And this happened in a sequence in the last years. As you can see, from 2011 to 2023, we've been following with a continuous lowering of the cases of malaria. And this brought the worry that I mentioned before, which made the researchers to look for the minister to talk about this point of making sure we have public policies, even though malaria will still receive the certification of elimination. So this was a very important meeting for the elimination of malaria. I think, Cláudio, this was a landmark in the commitment with the minister. Well, malaria is in Brazil, especially in the Amazonian region. And then we start a lot of the very important components of the challenges for this elimination. We talked about the elimination in the Amazonian region, but we do have a very important point, which is malaria in the extra Amazonian region from the point of view, and I here have to highlight from the last speeches I've heard with Cláudio about the mortality being so elevated due to the health professionals not knowing who are people who are not inside the Amazonian region, who are outside this public health support that you have in the Amazon. The malaria cases in Brazil, if you analyze, basically involving this period between the COVID pandemic and what we are currently living, COVID as an iconic point, everything that involved this period of the COVID pandemic. So here we have numbers that are varying between 140,000, 128 cases, and then from 2023 we start observing raising in the detection of cases, and also in this first semester we already had 70,000 cases, and that means half of the cases that were registered in 2023. This raising in the number of cases has brought a lot of repercussion in the media, because they understand that this is a raise in the number of cases. Raquel Aguiar is here. She's our communication professional who studies this field. She can explain this a little better in some of the discussions and how these narratives will be composed. And that basically is related to the assistance. The number of cases growing does not mean that we are having any kind of negligence in that disease, and that's the opposite. We can show in the numbers that we have in distribution of tests and diagnosis and the availability of and medications and health professionals in the areas. Basically, a plan that was done, and we are acting, especially in the state of Roraima, where we have the Yanomami population. About the deaths, this indicator is very important. If we have a bigger number of cases, and we can observe in the cases in the other year, we have a reduction in the lethality, and that reflects the care. When you look on the distribution by specimen, we understand that the majority of cases in Brazil is an endemic region, and so important for Plasmodium vivax, and also the Plasmodium falciparum, and also mixed malaria caused by the other species. Then we have what I was mentioning before, and when we talk about the social determinants, we are talking about people. We are talking about what that individual what makes this individual to be less or more exposed to that disease in that case. In this case specifically, we're talking about malaria. So when we have a cut in these special areas, we observe that from 2022 to 2023, we had a raise in 40.2% in the indigenous areas, and that is associated to the government actions that raised the access to the care in the indigenous areas, and that reflected not only in the number of people and also the registration. Which brings in under notifications in these diseases that were invisible in the areas, we start to identify it. We also have other numbers that we will mention, but I would like to call your attention for this percentage of 40% of malaria cases are in the indigenous areas and 20% in mining areas and 4.9% in settlement areas. If we add all this, we have almost 70% of the malaria cases, which are in areas of difficult access, in areas that are empty or were empty, and we are looking for the broadening of the access for these populations. What we see here from 2023 to 2024 is a growth in number of cases and transmission in indigenous areas, in the settlement areas, and also in urban areas. The map shows the dispersion, and that led to a migration from the indigenous areas to other places, which made the outbreaks of malaria happen in areas where they were endemic. This graph is very interesting because it shows in green the important reduction in the malaria cases in rural areas along the years. However, when we look at the indigenous areas, what is shown here in orange, and also in mining areas, you can see this number here in these populations that are in areas that are harder to access. As I mentioned, the obstruction of indigenous areas and the advancement in the consolidation steps, this is the importance of the healthy Brazil. We act with other ministries, and these ministries can develop some actions that we in health, are not capable on acting. The elimination of malaria in Brazil. So what is the vision of this plan? A Brazil without malaria transmission, reaching the global goal to eliminate up to 2035 the zero autochthonous cases and the intermediation landmarks, reduce the incidence for 78,000 cases for up to 2025 and 14,000 up to 2025, and also eliminate the contamination by Plasmodium falciparum. And this is very doable where we can reach up to this date. And in this moment, we are still outside the goal. As you can see here in orange, the channel of what we propose, and in terms of notifications, you can see in blue, and infection is the dotted line. So our challenge is to have a reduction and perform this reduction in the conditions, the social environmental conditions that I commented before. So this is not a small challenge, because when we see the municipalities, we have 80% of the malaria focusing in 30 municipalities. I'm looking at Alex just to check if the information is correct. So 30 municipalities, it looks easy. And we get together in a task force, and then we eliminate malaria. Now, I am going to repeat this. Well, this is a sentence that me, former President Fernando Henrique Cardoso said. If it was easy, I would have done. So this is a learning that we had to be among these numbers. So 34 municipalities, we registered 80% of the cases in 21. In 23, we have a reduction to 26 cities with 80% of the disease. And now talking more specifically about malaria by Plasmodium falciparum. We had an observation, Alex. You had said about this data, but you can comment later. Oh, yes. About the municipalities inside the goal. So we, from the municipalities in the country, we have 5,000 inside the goal, and we have 218 of these municipalities outside the elimination goal. So this is another cut that we have in this analysis. Well, where are we? About the diagnose and the treatment and the vector control. Here we have good news. We've been advancing a lot in this field related to the diagnose. We have a big area to make sure we do not have any lack of assets. This year we have implemented the test that is fundamental for the implementation of the treatment with quinaquine. We will talk about this later. And all of the assets for this methodology and this new technology are being given in constant phases of supplying for the fast test and also G6PD.
And talking about GCPD, we will discuss treatment. So today we have amplified the drugs available, medication available. ICMQ, ilometrofina, we have ICMQ already, chloroquine, and in June 2023, we have incorporated cetaphenolquina, which has a unique dose, so it reduces the time of treatment for liver cases, and there's the treatment as a whole that lasts for 3 days. And also chloroquine, so it's very important for Plasmodium vivax, and we still have some limitations of prescription because it can only be prescribed to people that are older than 16 years old. And it's a challenge because sometimes we are in areas that have people that are under the age of 16. So we have a very important component, which is a time for maintenance in the circulation, the bloodstream, which makes us have a smaller possibility for reinfections. It's not a process that began now. These studies began in 2014 with the group of Marcos Lacerda and other collaborators as well have participated of this process. Then after 10 years, we could have this medication in the endemic areas. I don't want to press the button too hard. Well, I'm not doing anything. I'm just right here. We keep pressing, and it makes things that you did before. I guess it's a little bit delayed. So there's vectorial control. So we know about insecticides. We know about impregnated bed nets, vaporizers, pulverizers. So we have advanced a lot regarding control of Aedes aegypti, but for malaria, we have many challenges to be put in practice. So we have many photos here for you, these controls, which you know a lot about. Oh my God. So we have been monitoring resistance to insecticides. So the introduction of new insecticides is also something that we can try to tackle this difficulty that was identified inside our team. We have professionals that are having their PhDs in this area, such as Roberto, Pablo, but in another area. So just to say that we have been working on it, on the control inside our group. Honan as well has been working on it, on this area. And we are creating a coordination of control for entomology, which is transversal. So we are going to talk about the vectorial control, not only for one disease, but in a coordinated manner among our coordinations. And sometimes we have leishmaniasis and malaria, and we have been working together. So I would like to talk about insecticides that are used for Aedes aegypti. Sometimes we can use it for bees as well. So in a context of health, we have to work in an integrated way. Leishmaniasis. So in the treatment field, we have been working on the implementation of tafenoquina, pediatric tafenoquina, and we have already talked about weight. There are studies that are being finalized, and now we will get into the process of incorporation. And in this implementation process, we have already 1,055 people that have been trained and people that have been treated as well. And we feared, there was something that we feared a lot in the beginning, and this was a topic of our meetings, of our technical meetings, which was the adverse effect. We have no adverse effects, and another worry that we had, another concern that we had was the access to this medication. It's already being guaranteed, and the training of professionals. So I am here in Awaris, This was a great visit, taking a look at the conditions in which our professionals are working. And this map shows what is programmed for 2024 and what we have to program for 2025. So there's the return of the production of handicraft, of artesanato and mefloquina. So this is a great step that we could have. There's the availability of this medication for treatment of children that was made with the help of Biomanguinhos, a facility of FIOCRUZ. There's the increase of acquisition of rapid tests. This has come together with this increase in the health units. So we have more diagnostics and we have the professionals and the products. So regarding insecticides, there's the change of etofenprox and clotianidina. So there's more resistance and prevention and actions that are important. And I would like to highlight the importance of our local supporters for control of malaria. They are present in something around 30 cities. We have had a great meeting this year, so we are thinking about reviewing, maintain what has been being made, but we have to amplify the scope of action of work of our professionals so that we can have more services for malaria. And the capacity building has been fundamental in this field. I'm sorry. There are elimination workshops that are going on in different parts of the country, especially in the Amazon. And there are the elimination workshops. I'm going to show you these 4 states where these workshops were made. So there is a planning that was made already. So what is in red, there's the percentage of cities and the states that are being prepared for the elimination. So in Amapá, no doubt it's going to happen. There is the superintendent that is there. Things are going very well there. So here we see Roraima State with a preparation of in 60% of the cities. There is Rondônia with 23% of the cities. And Rondônia has talked about something that is very important because the transmission in urban areas is what predominates. So this is a challenge, and we have to take a look at that. In each state, we have to really go deep into it and do the micro plannings so that we can identify where are the bottlenecks in each of these cities. In Amazonas, we have 48.4% is already prepared for elimination. And there is the support to researches, Malakiti. I can see here, Marta is here with a big smile on her face. This is a very fundamental strategy. And here we have our activities of education and health. So there is telemalaria, which is very traditional. We have been conducting it in Rio de Janeiro with a referential lab at FIOCRUZ. There was a telemal, which began recently. It focuses on malaria, but also in other diseases. So it is a strategy that has been made together with the digital secretary And it's important to amplify this access. Working here at Lumpy, which deals with diagnostics based on molecular biology. So yes, Brazil has the capacity to eliminate diseases. And in this picture, we were receiving an award, and there was also an recognition for the elimination of malaria, of some diseases actually, of filariose lymphatica as a health problem. And so Brazil has the capacity to eliminate malaria in Brazil. So here we have a challenge, which is the elimination is only one stage, and we are working on the filariose lymphatica. We're thinking about the post-elimination process. It's as important as the elimination process, and malaria knows about this, especially because after we saw that graph, and Brazil can count on this scientific community, our technicians, so that we can bring to these populations this program that might reduce this disease that has so much impact on our populations. So SUS has been working actively so that we can reach this goal. Thank you very much. I'm sorry, the disease is lymphatic filariasis. Thank you, Dr. Alda. Again, we won't have any questions, a question session, but I'm going to make a summary. I want to thank you for your brilliant presentation emphasizing. It's been 14 years that I am in the Ministry of Health. So thank you, Dr. Alda. It was very good. They participate a lot with us on the elimination of malaria on our program. We have our other diseases such as zoonotic diseases, arboviruses, now Hanseníasis and other diseases. So thank you very much. So now, taking into consideration her presentation, let's discuss elimination. When we talk about elimination, I've been 8 months in the coordination. I want to thank our researchers, by the way, and we have to think how we are going to eliminate this. We have tools for that. We can really eradicate malaria in Brazil, but one of the important points was the comeback of this coordination of elimination of malaria. So we have this goal. And for those that don't know, in the Ministry of Health, we had this coordination inside the arboviruses program, and my semi-colleagues started to work with us, and our team is very good. And our team depends on all of you, my colleagues, coordinators, endemic agents. So in malaria, our network is very strong. So at this point, we will be able to eliminate malaria because of this task force. So in these months that I am running this program, I was very well received in all of the states. I know all of the coordinators that help us. So this integration among state and cities and ministries, we won't be able to eliminate malaria without working together with these indigenous sanitary district. And at last, Dr. Mauro and Cláudio and Petauil and also Cássio, they visited us and we worked together with the Minister Padilha. As Dr. Cláudio said, we won't be able to eliminate malaria only with our strength and our researches and our works. We need also to integrate people politically. So we should have the support of senators, of federal and state level institutions. So we have to raise awareness, and this has been made with our politicians. So with the politics, we have money, and money allows us to work in a harder way, allow us to have more research, and this is what we want. So to summarize, Dr. Alda, that is it. We have a positive horizon before ourselves, but we need this political support with money. Without money, maybe we might take a longer time to eliminate malaria. Okay, so now have a very good scientific meeting. Thank you all.
Let's everyone take our seats. Let's follow with our meeting. Now, going on with our activities, we will start the roundtable with experiences in surveillance and perspective for elimination of malaria. Now, we invite the researcher of the Carabobo University, FCS Venezuela, Yasmin Grubu Panis. And as a moderator, the researcher of the Foundation for the Advanced Scientific Research in Paramaribo, Suriname, Stephanie Giovanni. Good morning. Welcome to this new session of this roundtable. And we will have three presenters, Dr. Alejandro Cuenta from the University of Peru. And Dr. Alejandro is a specialist in the infectious infirmities and tropical medicine with emphasis in infirmities transmitted by vectors. He has a doctorate degree in medicine in epidemiology, and he's a founder of the investigation group of leishmaniasis and malaria in the Institute Alejandro Conjumbo of Tropical Medicine in the Universidad Cayeta in Lima. He has more than 25 years of experience in public health and has organized programs of control in Peru, and also a program of malaria which diminishes the incidence in more than 50%. He has experience in planification and evaluation of health projects, and he's a member of many social, scientific, and he's a consultant of international organizations. We will invite now Dr. Martelise Essiel. She's the coordinator of the program of malaria and health in Suriname, and she's a doctor and specialist in public health, and she's a master degree in public health in the University of Tulane, and she's got a fundamental role now in Suriname. And before, she was a director of the Ministry of Health, where she was in charge of many initiatives, health initiatives, also the director of the management of crisis for COVID, and in the national program, and currently she's the coordinator of the program of malaria. This is a work focused in the elimination of malaria with strategies which include the improvement to the access to the diagnosis and treatment and the for the treated mosquitoes and mosquito nets, and also for the transmission. And in the Suriname, this is a very significant progress for the elimination of malaria, especially in remote areas, in Turiero, and especially the mining of gold mining areas, especially for migrating populations. And now I would like to invite Dr. Florencia del Puerto. And she comes from the National University of Asunción in Paraguay, and she's the investigator of the Institute of Science, the Health Science. Dr. Florencia is graduated in biology, and she's got a master's degree and doctorate degree in health. And she's an investigator of the Institute of Science Investigation of Health in Paraguay. And she's a specialist in infirmities caused by vectors, and especially including the detection, characterization of Plasmodium species using advanced techniques in PCR, and directed and monitored for the malaria vectors, and determining the potential of asymptomatic cases in endemic areas. Florencia was a fundamental pillar in the reinforcement of the country for the elimination of malaria, an infirmity of which we don't have cases reported since 2011. I invite you to continue. Alejandro is here for his presentation. Thank you. Good morning. Thank you so much for the invitation in this event. And for me, it's great to be here in Belém do Pará. I don't have any conflict of interest, and we will mention how we elaborate the program of control of malaria. And then we begin with the lessons learned. We have had two big programs in Peru, one with the eradication in the 50s and 2005, and both. So what is the causes and the project that started in 2005 until 2010 and reduced 80% of malaria in 4 years, but soon we lost all the effect, and 10,000 cases we have, and again 50, except for the ministry received the responsibility that left the program. We had many reasons for this. But what is happening? At the end, what happens is that we ignore the reservoir of malaria. We are focusing in only taking the symptomatic cases, and the symptomatic cases in Peru represent 2 to 15% only. Now, we have been ignoring the submicroscopic malaria and latent, and this is due to the diagnosis and only 100 parasites, and without parasites, and it does not detect others. So, based on this, we started the elaboration of a plan to verify it differently with the support of Ana Miguel. We have decided that we have three scenarios. One scenario of resurgence, which was the one that had control measures regarding sustainability. So there were economic power for the injured first people, and we had new outbreaks. And in a scenario, we requested the support of the Global Fund, and we were able to eliminate malaria, but this limit was 80 to 85%. So this determined that this was not sustainable because the amount of people we need year after year is really a big amount of people. So we decided to, what Ana Miguel said regarding malaria was, let's have a little more effort and eliminate malaria. And then at this point, we had new knowledge and technological that would make us eliminate malaria. So we decided to go towards this. We programmed an event with the support of with the Bill Gates Foundation in Quito to go to direct malaria. We had all the representatives of the ministries, international representatives. Dr. Vargas said in the morning, it was true. If you don't have any political support, there's no health program that is successful. So this was sensitivizing this political support. So then we had the mining plan for malaria for OIS with according to the high transmission rates and very low transmission. They each had different activities. And with that, we were complaining, and with this, we elaborated a plan, but we were also able to have the political support at the same time with the first program for more than 60 years, which was a public health policy. Public ministry supported this, but we also approved it by the state of Lori. And this was fundamental for having the money for this and allowed us to have a fund or money that was not that big, but much more for sustaining the programmed activities. This is the Zero Malaria Plan in Peru since 2018. It's got 3 phases, 1 phase. Phase number 1, which mentions the symptomatic malaria. Phase 2, that walks towards elimination, and phase 3, which is the elimination of malaria. And we have 25 to 30 years, so I could talk about it in a bigger detail. And in phase 1, when you had the goal to reduce the symptomatic malaria in 70%, because the symptomatic malaria is the one that contamines the most, so we reduce the endemicity. And using the strategies, the improved strategies through the PAHO program. This is the management of cases with the early diagnose and the combined testing and a course of microscopes and the dominance of these health vectors. The massive use of mosquito nets and the creation, the elimination of the insects, and this logic is in real time. All of this goes back to capacitation of the public ministry in specific activities and moves the community for their participation, which quickly understands and compromises the community. So it's hard to move the community. The problem is that the high-level workers could understand. or improve their diagnosis and treatments, and at the same time the system of distribution for the medication in adequate conditions, and then having the opportunity to distribute. And Peru already knew how to do this, but sometimes we forget. And then we went back to doing this. In phase 2, it's the elimination path. So that means this time, besides doing the symptomatic malaria management, we have to perform the treatment for the asymptomatic malaria. So we need mass treatment because the population could be infected and never been treated. And this leads to new methods for diagnose in community levels, and the treatment also in community levels. In this phase 2, we have an expectation that there will be changes, and it's necessary to adapt the fast tests that will be less efficient, because when you lower the density in the parasitary chamber, it's lower. When it's lower than 10 in fast tests, we use a lot of tests for positive results. So the microscopes is always also lower in efficiency because there will be a lot of asymptomatic cases. And also the strategy that we have for the symptomatic case and for the active search of cases also progressively will be lower because there will be lower cases. So other measures like the health ministry, which I don't really agree, but they enjoy doing this, we will have less sweeping and not efficient, and necessarily should be an element that will eliminate and start lowering to lower levels of malaria to avoid the reactivation. And in phase 3, talking about malaria in residual time, and at least 10 years with 2 basic elements. The first is to detect the transmission focuses, and which means the hotspots, as my friend would say, this is the origin of malaria. And the other is the migration problem. Migration not only favors the retransmission internally, but also inside the communities, in the bases. That shows the migration has standards or channels for migration. So what do we expect in changes of phase 3? That the microscope and the optic researches have lower value, and the methods, the parasitological methods, have lower value too. PCR will also lose sensitivity. So we bring new methods for diagnose, which are already showing. So the treatments are not only in the individuals, but the treatment for the focus, the hotspots. So probably if there are vaccines, the vaccines will be essential. The value and the vectorial management will also change, and probably we will need to find new strategies for the use of the treatment in Peru. So this plan is a theoretical plan, but it's necessary. So we will see what situation we have in Peru currently about malaria. We see in 2018 that we had a reduction in the first 18 months of almost 60%. But then we had the pandemic, and the pandemic immobilized, especially in Peru, the program of malaria control in all the places we had tests. The cases were low because they were not reported. The mobilization from the government did not affect the communities, and the migration also reduces the effect, but not for the program itself. And this is the situation of Peru. 96% of the Peruvian Amazon and 15% falciparum. As you can see, both in blue and also in orange, the curves will tend to be established. We have a bigger transmission and lower transmission. So in the malaria, it indicates a very big rise. So the biggest rise is in 2024. And there were outbreaks. There are registrations because the program is being reorganized. And we also had two problems with La Niña, El Niño, and also they were, and in a few years we had illegal mining of gold. So far, the program is able to relatively control the outbreaks. But we did not expect to eliminate the malaria. Now, the technical problems we've got. The first of them, especially the concept, the reservoir, is 20 years. The concept is not only asymptomatic problem, of course. If we do not consider the importance of the reservoir of malaria, these are the scientific evidence we have in Peru about the importance of the reservoir. And the other problem?
Go through an intervention. So it's very important. We could see that the transmission happens, especially in the basins and rivers. So there's the importing of malaria, and inside this area we have heterogeneity. We have low transmission areas, and we have a cluster type of transmission. Not all communities have the same levels of transmission, but it's concentrated in some areas. This makes us focus on micro epidemiology to act. So it's necessary to be adequate to fit in each scenario. So as a product of it, for example, if in Peru we acted throughout the entire Amazon, we would. So what means is that 50%, this represents 200,000 people. So in terms of planning, this is different. So on our right, there's the city of Andoas, which is a city with the highest levels. In indigenous communities, we have also high transmission rates, above 50%. So we have to start from there. And this is where we have the greatest challenges for the future. So the micro extractification, micro layers should be identified. So how can we diagnose symptomatic and asymptomatic malaria people in field conditions. So we're not talking about a routine program. And we can demonstrate with our studies that the passive detection is insufficient. When we make an active identification, we go by house, for example, 4 times a month, and we multiply it by 4 the number of cases of infection. Of course, we cannot do this every week. This should increase the number of cases, but this is going to make us have a lower parasitary charge. Not as symptomatic, but yeah, it's complicated because we cannot do a PCR with lots of people. So of course we used LAMP, and we have relatively low costs for the use of LAMP, and it diagnoses 5 times more cases. So we are convinced that despite this being popular, it's still expensive and it's hard to implement it on big populations. So if we make an intervention, we have to intervene in all places. And if we intervene in all of the basin, and then we can reach out to bigger populations. So what alternatives do we have for mass diagnosis of asymptomatic cases? What are the monocular cases for the future? So what was described by Marcelo's group is the active detection of cases. It allows us to identify an index case, and the entire family is considered infected then, and then the neighbors in 2000 in a ratio of 200 meters. So we want to act on the majority of people. And so we have been testing this now, and in the future we will have a response. But this is a good alternative, and since we don't know how to identify the asymptomatic cases on the field, but we know that the current cases will have low numbers, will have low value, and also treating the person individually. We cannot justify the mass treatment, but evidently, because of what I said, we have to identify the new hotspots, because in the hotspots we have the malaria generation. It is the last that appears, but it's the first that is highlighted in the community, because there are methods, serum methods to identify the infections in the last 6 months. The problem is that it's on paper, but we don't have practical tests yet. And finally, we have a new radical cure in here. We received the use of caseroquina, which can be used in Brazil, also measuring weight and using an algorithm. To summarize, a substantial change in malaria elimination is the elimination of the reservoir. And this asks for a change in strategy. So what are the challenges? First, the professionals of health have to accept that we are trying to use different plans, and they cannot use things that they have used for all times. So we should try to fit this new knowledge And we need a new method that is simple and that can be made on field. And the new radical cure is a hope that will increase notably the rate of elimination of malaria using tafenoquina and tafenoquine and in previous analysis, with previous analysis of glycosis and phosphate. And I'd like to invite, to thank Marco Lacerda, Cristiane Ferreira, because of the works that we have made together. And they have offered a lot of knowledge for the malaria planning. Thank you very much.
Bit of Spanglish, so if you don't understand, you can still take a translation device. Okay, we want to like to thank the organizers for inviting Suriname to share our experience in malaria elimination. This I had to put in the slideshow of the organizers. I earn no money nor personal gain from my work. This is Suriname. Suriname is part of the Guyana Shield and also the Amazon. We are a very small country with a small population of maybe 500,000 people. And we have natural boundaries or borders with Guyana, Brazil, and French Guyana. And we are aspiring to request WHO certificate of malaria elimination by the mid-2025. And we want to show our experience in the past and the road ahead. Here you see the history of malaria in Suriname. As Peru said, we had calm days between the 1960s till the 1980s, where we didn't reach elimination level, but malaria was pretty much under control. But let me see how this works. There was a civil war in the interior, guerrilla war, and that lasted for about 6 years, during which there was a lot of movement of people, and the health infrastructure was destroyed. So there was a big outburst of malaria, even spreading to the Savannah area behind our capital city of Paramaribo. We had a lot of cases. And most of the cases in those days were falciparum cases. So we had many severe cases and deaths of malaria. But gradually over time, this proportion decreased substantially due to the availability of artesunate combination therapies. So in the past 10 years, or maybe longer, we see mostly 5X. This is the summary of interventions over time. We started with BetNet distributions, and then came the breakthrough of the introduction of rapid diagnostic test and artesunate combination therapy. And that was thanks to the RAFEDRA project. We're very happy to be here in Billing again, where the RAFEDRA project started. The distribution of long-lasting insecticide-treated nets. We started with an MSD network. I will come back to that. And a single dose of primaquine for the treatment of falciparum, we think also contributed to the decline of that disease. We then moved to the gold mines gradually and distributed the nets also there. And the last intervention we had was with Malakit. I come to that also. But crucial in our fight against malaria has been the establishment of a National Malaria Board, which is kind of a multidisciplinary committee appointed by the Minister of Health, consisting of representatives of the primary healthcare organizations, malaria specialists, public health specialists, and academia. And this board sets the approves and coordinates the effect of the interventions. And this board exists to date. In fact, Dr. Frieden and me are member of the board. It's currently renamed as the National Malaria Elimination Task Force. This body has been indispensable in our control of malaria. The last indigenous case of malaria, of falciparum, was in 2019, so even longer than 5X. And the last indigenous cases of 5X occurred in October 2021, which makes us eligible for applying for the certification of elimination. Here you see the number of cases by classification, and the second column is the years, and in the red box you see that for the past 3 years we had 0 indigenous cases. And in the lower red box you can see that there are still some imported cases, not so many, between the 50 and 100 a year, all from the surrounding neighboring countries. And most of them 5X, more than 95%, I would say. My voice is going away, the dry air probably, you know. Here you see the disappearance of the ecti foci over time between 2000 and, thank you so much, and 2013. Thanks. Thanks to the introduction of artesunate combination therapy, because the red balls are all falciparum. So, how did we establish this in our scenario? Our case is that we have a primary healthcare organization called Medical Mission, who manages 50+ clinics scattered all over the hinterland of Suriname, serving Maroon and indigenous communities. Even near the border with Brazil, all the green dots are Medical Mission clinics. And they were heavily involved in the access to early diagnosis and treatment of the malaria cases. So they have been instrumental in eliminating malaria from the stable communities. Nowadays, they focus on strict measures aimed at preventing reintroduction in the communities. So what does that mean? In 2019, 5X was imported again in 2 villages near the border with Brazil, Tepu and Palomeu, and it took us 2 years to control the 5X. And the villagers clearly remember that, because we had repeated ACD and MDA activities carried out. So nowadays, they have 0 tolerance to malaria. And Medical Mission really encouraged the villagers, for their own safety, to refer all visitors coming from malaria endemic areas immediately to the health post, which happens. Here we have a picture of a recent picture taken from a Amerindian village where there recently were a few imported cases. And we immediately started with an RECD campaign. So this is a picture from that. But even if there are announcements that a family from across the border comes, or other population, other people, for a soccer game or for a Bible conference, Medical Mission tests everybody. So they go there, and in an event that was organized September, they tested Amerindians from Misao and Kusari. Luckily, everybody was negative. So this is a way to keep malaria out of their territories. Okay, in this graph, you see the decline of malaria nationally in the yellow line, but you see a gradual increasing line, which is in the gold mining population. So after the elimination in the indigenous population, then we were focusing on the gold mines. And there we created another network, which is the Malaria Service Deliverers Network, with their task to assist in rolling back malaria in hard-to-reach gold mining areas. We wrote a grant for Global Fund and got it approved. And the grant was named Looking for Gold, Finding Malaria. It took 2 or 3 revisions, but it was eventually approved. And who are they? So we started a pilot project in 2006, but this system is still operational now. They are recruited from the gold mining area, so they earn their living from the gold mining area. They are cooks or what else, boatmen, or maybe garimpo themselves. And they have to have an adequate capability to read and write, and they get a monthly stipend by our program, the Malaria program. In return, they must offer services for free and report. They fill in a form. The form is in Portuguese, so it's not difficult for them. They take a picture and send through WhatsApp or another medium to us. They get a formal training program for of the malaria program, where they learn how to do a rapid diagnostic test, how to prepare and even stain a blood smear, because for each rapid test, they have to make a blood smear which is red in a laboratory regionally or in our malaria program. Because sometimes the rapid test, that is our experience, but Dr. Frieden can explain maybe later, fails. And then the microscopy is the golden standard. They treat, they do a case investigation. The travel history is extremely important to write down. They are also trained in biosafety, stock management, and they do reactive case detection. And they distribute bed nets and also malakit. So they are supervised by a MSD supervisor who are more senior people, and there are weekly calls and supervisory visits. And the supervisors report to the responsible staff in the malaria program. Okay, here you see a diploma. They get a kind of a certificate. They are trained annually, and we have an upcoming training even in December, where we will train them in what the malaria elimination visit of WHO might mean. So, and to the right you see we have a very nice malaria service deliverers training manual developed for us. Okay, from our surveillance data, we see that 63% of all rapid diagnostic tests and slides in Suriname were actually made by MSD. And so they contribute a lot to the malaria case finding. And 40% of all the positive cases were actually detected by the MSD. So the MSD play a crucial role in the prevention of malaria reintroduction in our country, we find. We try to scale up testing in those mobile populations. We have established a border post with Guyana, where people traveling from the gold mines in Guyana travel through Suriname. They get free testing, treatment, and provision of the nets. We also have a facility, similar facility, at the border with Guyana. What we also found that many of the garimperos, they stay in our capital city, Paramaribo, to shop, and then they go back to any gold mine. So we try to even offer testing in supermarkets. So today is the 6th of November. We have in a supermarket called Transamerica Supercenter, we have a testing event going on at this moment. I saw some pictures, and it seems to be highly attended. So in fact, the idea is to test while shopping. Okay. Transborder malaria is a problem, and it was mentioned already, because the garimpo, they come from areas with no diagnosis, treatment, and they can get ill there. We have had a woman, she got malaria, falciparum malaria in Roraima. In Roraima, was it there? Was it in Roraima? Yes. And she ended up in a hospital in Suriname with severe cerebral malaria. And in fact, you can prevent this if you have a self-testing kit with you or you have MSD anywhere. She made it and came back to Brazil for revalidation. Inadequate use of counterfeit antimalarials can induce the development of resistance. And so that's why we started with a Malakit project together with the French and Brazil. The first project was 2018 to 2020. People get a self-testing kit and with medicine in it, antimalarials. And for Suriname, the results were that malaria in the French-Surinamese border dropped by 76%, and the proportion of falciparum dropped even by 83%. So based on these results, we are confident that Malakit plays a role in malaria control and elimination, and we included it as a tool in our malaria elimination efforts. And now we have translated this Malakit, the instructions for the travelers, into Chinese, English, and Spanish even. And we will give it to the people that travel over our western border towards Guyana or Brazil. The challenge of 5X was elaborated upon by the previous speaker. We see relapses, many relapses months after returning from a malarious area, and the adherence of 14 days of primaquine is challenging, and it is not applicable in the mobile populations. So tafenoquine can solve this problem, but the requirement is G6PD testing. We tested G6PD in the indigenous villages near the southern border. We tested about 1,100 villagers, and 90+% had normal activity. So this made us confident that screening of all villagers of the remote indigenous communities and recording the result in their medical record could really enable us to contain outbreaks quickly using MDA with tafenoquine. This is for the future, okay? Also, tafenoquine, the MSD, the malaria service deliverers, were also trained in the G6PD, using the G6PD device. And but the test devices have not been distributed since tafenoquine still needs to be registered in Suriname, and there are some procurement issues to be finalized. But we have put a request at the Ministry of Health of Brazil to provide us with limited quantities to start at least a pilot using tafenoquine in the mobile migrant populations. So the challenging final lap towards certification of elimination for Suriname means that while we are preparing the elimination dossier, still imported cases end up in our gold mines or wherever. And we have to have two parts. One is writing up everything, training your health workers, and the other part is really pursuing each case that appears. Each case has to be classified, determined, and decided if we do a reactive case detection or community reactive case detection. What happens all the time? So it's costly, but it's the only way to prevent reintroduction. Collaboration with neighboring countries we find very important. That's why we're here also, because elimination requires not just a national but a regional approach. And so to sum up our road to malaria elimination, so having a network of testing and treatment for everywhere where people are. So even if they are resident populations or gold mining populations. We even are thinking now about expanding our MSD network since the gold price is increasing and new camps are emerging. So as we speak, we are planning in Suriname to increase the MSD network, screening at the borders, screening in urban areas where gold miners gather, promotion of the self-diagnosis for travelers, looking for innovations in the treatment of P5X, and rigorous case finding and reactive case detection, and if needed, MDA. With malaria, we're never finished in Suriname, we feel. Certification is not the end of the road. We live in a geographic area that is very receptive for the transmission of malaria, so we're in this together with our Amazonian friends. Thank you.
Muy buenos días a todos. Muchas gracias por la invitación a los organizadores. Realmente estoy muy feliz de estar acá, de compartir con ustedes. Es la primera vez que estoy rodeada de tanta gente experta en malaria en la región. La verdad que quería hacer esta presentación y contar todo lo que hicimos dentro de lo que fue nuestro apoyo a lo que fue durante la fase de preeliminación de la enfermedad. Quiero empezar contando que yo había hecho mi maestría y mi doctorado relacionado a la enfermedad de Chagas, y yo estuve en el extranjero y vuelvo a fines del 2012 a Paraguay. Cuando Paraguay se encontraba en la fase de preeliminación de la malaria, y es en el 2013 cuando ya ingreso a mi laboratorio, recibo este desafío de empezar a ver la forma de colaborar con esa enfermedad. Parte de la presentación donde se declara que no hay conflictos de interés. Como les decía, era 2013, Paraguay estaba en la fase de preeliminación de la malaria. Para serles sinceros, yo nunca antes había escuchado de malaria en mi propio país. Es más, la palabra malaria tal vez no se usa tanto, sino se usa una palabra en guaraní, porque en Paraguay habla español y guaraní. Entonces, con el tiempo, cuando fui haciendo el trabajo, fui viendo que en realidad la zona históricamente endémica no maneja la palabra malaria, sino más bien maneja algo, malaria en guaraní sería acanunduro, ¿sí? Más que nada significa el hecho ese de tener el temblor, el escalofrío. Esa es la traducción del guaraní que define lo que es la malaria en Paraguay. Yo nací al sur, entonces no tenía idea hasta ese entonces. Entonces, ¿qué pasó? Me dicen, bueno, trata de impulsar lo que sea diagnóstico de biología molecular dentro de lo que es esta etapa para poder ayudar y buscar casos asintomáticos. Entonces empiezo yo a tratar de leer lo más que se pueda para ver la punta del ovillo por donde podía empezar este desafío. En Paraguay, nuestra especie autóctona es el Plasmodium vivax. Y bueno, ya habían mencionado los profesionales que justamente Plasmodium vivax tiene esa característica que hace relapse cada tanto tiempo. Les decía yo, estamos en 2013. El último caso que se reporta, el caso autóctono de malaria en Paraguay, es del 2011. Entonces, la idea era ver qué podíamos hacer para buscar casos asintomáticos. Entonces ahí es donde yo me acerco a lo que se llama el Servicio Nacional de Erradicación del Paludismo, dependiente del Ministerio de Salud Pública, para pedirles un poco la ayuda de ellos, porque ellos tienen el programa de malaria, para que ellos me den un poco esa orientación de cómo abordar y cómo yo podía ayudar poniendo a puesta el diagnóstico molecular. Es así que, gracias a ellos sin dudar me dieron acceso a toda la base de datos que tenían y tenían perfectamente, digamos, inclusive me ayudaron en los cálculos estadísticos para tamaño de muestra. Es así que se puede ver ahí que hay 3 departamentos que quedaron como los departamentos históricamente endémicos. Entonces, trabajamos en conjunto con ellos, como son los expertos en microscopía también, salimos juntos al campo, conseguimos fondos para este proyecto que fue financiado por el Consejo Nacional de Ciencia y Tecnología. Ellos se dedicaron a hacer lo que era el gold estándar, el método de diagnóstico gold estándar, que era microscopía, y ahí quiero hacer un énfasis después en resultados, guarden eso en la memoria, que ellos fueron los que hicieron la microscopía, método gold estándar, y a la par muestreamos nosotros en papel de filtro, llevamos el papel al laboratorio, hicimos la extracción de ADN e hicimos la PCR. Una metodología que ya estaba reportada y conseguimos publicar ese trabajo, que es un trabajo que nos costó mucho, porque acá también hay que hablar de los desafíos que uno tiene en demostrar al mundo lo que uno está haciendo. Nos llevó prácticamente 2 años tratar de publicar esto, porque la mayoría, las veces que nos rechazaban, decían que esto era solo de interés local. Y a mí siempre me llamó la atención porque Paraguay estaba en fase de preeliminación, ya no habían casos autóctonos, y a mí se me hacía que era una linda historia demostrar que Paraguay estaba haciendo de todo, estaba haciendo todo lo posible por tratar de demostrarle al mundo que ya tampoco no habían casos asintomáticos. Nosotros fuimos a muestrear 15 localidades, la mayoría caen en lo que es el departamento de Caguazú, una muestra cae en el departamento de Canindeyú y 3 en el departamento de Alto Paraná. La mayoría de ellas son colonias justamente indígenas, y también fuimos a colectar mosquitos anófeles de las mismas localidades. ¿Cuál era el criterio? Ir a aquellas localidades que reportaron casos los últimos 5 años antes de ese silencio, de ese último caso reportado en el 2011, ¿sí? Ese fue nuestro criterio, y ustedes van a ver ahí justamente que los resultados de PCR dieron todos negativos, y la microscopía también dio negativa. Acá ustedes pueden ver, no sé si puedo retroceder, no. Bueno, también hicimos la PCR en los mosquitos anófeles, y en el gráfico anterior teníamos la distribución de toda la cantidad de mosquitos anófeles que colectamos en cada uno de esos departamentos, ¿sí? Y como les decía, algo que a mí me llamó mucho la atención, antes de pasar a la explicación de estos slides, es justamente cómo nos costó tratar de sacar a luz este resultado y tratar de contar lo que hicimos para decir, bueno, hicimos un monitoreo, tratamos de buscar casos asintomáticos, por el momento en humanos y vectores. Y nos decían que eso era de interés local, y parte de lo que nos rechazaban nuestra publicación decía porque no hicimos el método gold estándar. Y yo vuelvo a escribirle al editor y le digo, no puede ser, porque es lo primero que yo digo en materiales y métodos. Entonces esa fue uno de los desafíos un poco extraños también a los que nos enfrentamos. Era como que no había algo ahí que inclusive yo le dije al editor, cambien el revisor, por favor, tal vez haya un aparente conflicto de interés, pero finalmente cambiamos de revista y conseguimos publicar este trabajo que es hermoso. Ustedes ven acá cada uno de los mapas de esa zona que antes era históricamente endémica, ¿sí? Son zonas que ya hoy en día son muy explotadas para la agricultura. Todo lo que ustedes ven en fucsia corresponde al suelo suelo, tierra. Lo que está en verde limón ya es pastura. Y tenemos más mapitas. Solamente lo que está en verde oscuro corresponde a lo que es, digamos, un poco de bosque. Esta zona, si bien Paraguay fue zona malárica en los años 50, básicamente todo el país, se hicieron varias campañas y la zona endémica fue achicándose, digamos, y se redujo a estos departamentos que yo mostré en los primeros slides. Y eso es justamente lo curioso. ¿Qué hizo que, a pesar de todos los esfuerzos que se hicieron durante todos esos años, los que realmente trabajaron en esto fue este Servicio Nacional de Erradicación de la Malaria que yo les mencioné? ¿Por qué quedaron estos últimos departamentos? Y estos estas localidades están rodeadas por un lago. El Anófeles, a diferencia de la Aedes aegypti, necesita un lugar un poco más, no es como la Aedes aegypti que se ubica y que crece en cualquier, que se cría en cualquier lado, ¿sí? Entonces, el lago le da ese ambiente, ese hábitat que necesita de agua más o menos limpia, una zona palustre. Entonces, también eso ayudó, a pesar de que con los años la zona cada vez fue siendo explotada para la agricultura. Estas son otras imágenes de las localidades de Caguazú. Ven, casi, como les digo, no se ve tanto verde. Esta es la zona justamente que es circundante ya al lago, donde fuimos a muestrear los mosquitos, fuimos a colectar los mosquitos anófeles. Todas estas fotos fueron tomadas del trabajo de campo que hicimos con los entomólogos de este Servicio Nacional de Erradicación del Paludismo, que es dependiente del Ministerio de Salud. Y tuvimos la suerte de que estos entomólogos son personas, por sobre todo ahí el señor de gorro amarillo, es una persona que estuvo hace ya muchísimos años trabajando y él sabe perfectamente cómo fue evolucionando la zona. Él justamente a la par que íbamos viajando para colectar las muestras decía, esto antes era así, ahora ya no está esto, ya no está esto. Entonces íbamos teniendo esa imagen también a través de él, del cómo era la zona donde estaban estos mosquitos. Ellos hacían directamente ahí en campo todo lo que era la descripción, la identificación taxonómica, y ya nosotros directamente del campo llevábamos al laboratorio para lo que era el análisis molecular. Así es como se ve ya en fotos esta zona. Ahí se ve una parte del lago, ¿sí? Y también a la par tuvimos otras publicaciones dentro de este proyecto piloto que hicimos. Surgieron otras publicaciones como por ejemplo, al ir estandarizando la PCR, ellos justamente nos llamaron porque tenían algún que otro caso importado y nos dicen, tenemos un caso de Plasmodium vivax. Y para nosotros era muy caro conseguir, era muy difícil conseguir los controles positivos. Entonces le digo, pedirle permiso a esa persona para poder tener su muestra y usar nosotros para estandarizar nuestra PCR. Ellos lo hicieron por el método microscópico y habían diagnosticado a esta persona como infectada por un Plasmodium vivax, pero cuando le hacemos la PCR nos dio que era un caso importado de Plasmodium ovale, que inclusive le sometimos a secuenciación para estar seguros y nos arrojó que era la especie Plasmodium ovale curtisi. Entonces fue ya el primer caso importado, diagnosticado en Paraguay por métodos moleculares y que ya discriminaba perfectamente por el tema de la morfología, que el vivax y el ovale son muy parecidos. También fuimos un poco más profundo a otra localidad indígena, donde realmente la cantidad de mosquitos que colectamos había sido, la densidad de mosquitos era muy alta, y fue una de las localidades que antes del último caso reportado autóctono era uno de los que tenían mayores casos. Fuimos ahí, aumentamos la N de muestreo y también ya no encontramos ningún caso positivo asintomático. Y otra cosa también importante, nosotros, según la literatura, según lo que ellos ya tenían en sus archivos, la especie Anopheles darlingi era el vector primario para Paraguay y el Anopheles arbitarsis era el vector secundario. Sin embargo, nosotros en esa época, que fue más o menos entre 2014 y 2016, que se hizo todo el muestreo, ya no encontramos en esa zona Anopheles darlingi, que fue el vector primario. Entonces, fuimos a muestrear humanos, fuimos a muestrear vectores, a ver si alguno tenía algún parásito plasmodio circulante y no encontramos. El Paraguay, ustedes ven ahí, ciertamente fue declarado o certificado libre de malaria en el 2018, un poquito después ya de que nosotros terminamos el proyecto. Y como estábamos ahí, quisimos ponerle otro componente más, que era, ¿será que hay algún animal que pueda ser considerado reservorio? Entonces ahí me entra la duda de, bueno, ¿qué tipo de animal? ¿Cómo muestrear? No solamente ya vectores. Consulto con alguien que era un experto de Portugal en malaria y me dice, era un amigo, y me dice, Florencia, eso es muy difícil. Y logísticamente es muy difícil, me dice. Entonces empiezo a pensar qué estrategia podíamos hacer para abordar con pocos recursos, porque si bien teníamos fondos para ese proyecto, el proyecto estaba enfocado solo para humanos y vectores. El tema era qué hacer ya con fondos limitados, cómo ir a ese paso, por lo menos empezar algo. Es así que se nos ocurrió ir a, ustedes saben que la Itaipú Binacional es una represa que compartimos, una represa hidroeléctrica que compartimos con Brasil, y del lado paraguayo tienen una reserva natural. Ellos tienen, dentro de esa reserva natural, también tienen lo que es el Centro de Investigación de Animales Silvestres de Itaipú. Y justo toda esa zona también cae dentro de uno de estos 3 departamentos que son zona de estudio. La idea era entonces acercarnos, ver si podíamos trabajar en colaboración, y la pregunta era, ¿a qué animal muestrear? No era que uno tenía que ir y a mansalva meterles alguna aguja o algo invasivo para extraer sangre. Entonces, otra vez, de vuelta a leer la literatura, y ver que la literatura decía, obviamente los monos están relacionados, ¿verdad? Y después habían otros papers que citaban el tema de las aves. Entonces teníamos claro de que podíamos ir a ese centro de animales silvestres y trabajar y hacer el muestreo en monos y aves, al menos. El tema es que tampoco, no a todos los monos y no a todas las aves, porque por cuestión de bienestar, de bienestar animal, también uno no puede ir a hacer por hacer las cosas, hay que tener un cierto pienso. Y de vuelta nos preguntamos, bueno, ¿cuáles son los animales más nuevos? Porque hay varios animales que a veces vienen, que son rescatados, realmente son de la zona. ¿Cuáles son los animales que se puede decir que tienen cierta edad y que ya vienen habitando ahí la reserva desde que hubo los casos reportados? Entonces tuvimos una cierta N y ahí justamente estamos trabajando con ellos. Esos son las 29 muestras que obtuvimos entre loros, guacamayos y monos. Todos ellos dieron negativo también para la PCR. Y bien, hasta ahí entonces abordamos lo que fue vectores, humanos y reservorios silvestres. Ahora lo que tenemos de perspectivas futuras, así como tardamos mucho tiempo en publicar ese trabajo, nuestro siguiente desafío es tratar de publicar este otro trabajo que tenemos ahora, que también así nos está costando ya casi 2 años. Este trabajo lo hice en conjunto con una persona de Venezuela. Ella es una experta que maneja el uso de ciertos softwares que lo que hacen es predicciones de variables bioclimáticas que favorecen a que el mosquito pueda habitar en una zona. Entonces, un día, como surgen las cosas a veces, entre festejar un cumpleaños, comer una torta en el laboratorio, era, hola, ¿qué tal? viniste de Venezuela y te quedas acá en Paraguay, ¿sí? ¿Y qué haces? ¿En qué consiste? Y en un bla, 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 ella dice, yo sé usar este software y hace predicciones de variables bioclimáticas. Ah, yo muestré en tal parte, fui a colectar mosquitos, ¿qué tal si junto mis datos, tu experiencia y trabajamos juntas? Salió este trabajo muy lindo porque ahí lo que refleja es de todas las variables que ella sacó, justamente habla del... sería en inglés precipitation of wettest month, los meses de mayor humedad, lluvia, ¿verdad? Eso sería una de las variables que, cruzando con lo que fue nuestro muestreo, nos tira esa mancha negra que está en el mapa, que justamente coincide, ¿verdad?, con el sitio de muestreo, y nos muestra que en todo Paraguay esa variable que le gusta al mosquito para criarse está muy presente en esa zona, que a Paraguay le costó por años tratar de eliminar la malaria en esa zona. Porque, repito, Paraguay era enteramente malárico en los años 50 y las campañas lograron reducir bastante, pero hasta el 2011 eso estaba todavía ahí reportando casos. Entonces, esto también es la primera vez que estamos generando un análisis y unos resultados con prueba científica de cuáles son las variables bioclimáticas que ayudaron tal vez a que justamente cueste más eliminar la malaria en esa zona. Por lo que nosotros nos preguntamos, hay otros spots ahí que están en oscuro, que son zonas que ya no pertenecen a zonas históricamente endémicas, pero nos preguntamos si realmente también podríamos ir ahí a muestrear y tratar de actualizar ese software. Bien, eso es todo. Muchísimas gracias por su atención. Gracias.
Okay, thank you. Good afternoon, all. We have been listening to 3 wonderful presentations, all related to all with different accents. We heard about submicroscopic malaria. We've been talking about involving communities in malaria elimination, and we heard about mosquitoes, in which malaria was detected with a PCR. And I'm sure there will be questions to all these excellent presenters. I suggest that if you have a question, that you approach the microphones in front of the room, and that you introduce yourself, and please let's limit ourselves to just 1 question per person, because we want to allow as many as people to participate in this discussion, for which we unfortunately only have about 20 minutes. So there's 1 person.
Sí. Gracias. Voy a preguntar a mis compañeros de Perú, entonces hablo en español. Gracias por la presentación. Son tópicos muy interesantes y muy importantes para la región. Tanto Alejandro cuanto la doctora Matisse presentaron datos acerca del tratamiento y prevención de las recaídas de Plasmodium vivax. Entonces, la pregunta, y presentan esta preocupación con la implementación de la dosaje de G6PD como una de las limitaciones. Seguramente reconozco que esto es un un desafío a nosotros para implementar esto en la región. Pero específicamente, pero creo también que vivimos en una situación donde hoy hay aparatos de campo, hay aparatos que nos permiten utilizar estas cosas mucho más cerca de los pacientes. Entonces, me pregunto y pregunto a ustedes si es la cuestión de ¿qué necesitamos para eso? ¿Cuáles son exactamente los desafíos para implementar las pruebas de G6PD? Porque creo que esa es una mejor calidad de salud. Si intentamos pasar a tafenoquina, si intentamos pasar a una dosis doblada de primaquina, esto es una cosa necesaria para la seguridad de nuestros pacientes. Entonces, exactamente, ¿qué piensan ustedes? ¿Qué realidad se piensa que se puede hacer posible o no? Muchas gracias.
Gracias. En primer lugar, las recaídas por el momento son manejadas como si fueran nuevos casos. Sin embargo, evidentemente cuando las recaídas son frecuentes, ya se está pasando al esquema de duplicar el tiempo de tratamiento. El esquema de 0.5 miligramos por kilo por 7 días se está duplicando. Todavía no tenemos una directiva muy clara sobre eso. Y recientemente la Organización Mundial de la Salud también está definiendo mejor el manejo de las recaídas. El mayor problema de las recaídas son en los niños. Entonces, como política no tenemos nada específicamente, pero como manejo de pacientes individuales sí. Cuando tenemos niños que recaen una y otra vez, simplemente los pasamos a esquemas de 15 días, descansan un par de semanas, se les hace una evaluación de una prueba, una gota gruesa, y si está positivo se lo vuelve a dar el esquema, inclusive siendo asintomático. Y con eso se está consiguiendo controlar. Pero no hay una política todavía que es necesario, evidentemente, que va a tener que agregarse posteriormente.
Okay, thank you. Thank you. There's another question.
Alô, Walter Ramalho, Universidade de Brasília. Fiquei muito impressionado com essa mesa, parabéns aos organizadores, mas a minha pergunta é especificamente para a doutora Florência de Puerto, no momento que apresentou um modelo de habitat natural da malária. É muito interessante essa abordagem e eu gostaria de fazer, na realidade, uma pergunta a respeito do software. Fiquei curioso a respeito da facilidade, inclusive, de, na sua opinião, exportar ou ampliar essa expertise para outros países. Muito obrigado.
Hola. Muito obrigada. La persona de Venezuela es la experta en este software. Ellos usan Maxent. Ella trabaja también con gente de Venezuela. Se llama Maxent el programa. Y tengo entendido que este programa tiene datos grabados de más de 30 años de todas esas variables, ¿sí? Es como que tiene grabado todas estas variables que fueron pasando por 30 años. Entonces, eso es lo que se cruza. Nosotros justamente ahora vimos hace poquito una apertura para postular a fondos y dijimos, ¿por qué no postulamos y pedimos otra vez como para hacer una nueva colecta de mosquitos y tratar de actualizar también nosotros nuestros datos de colecta para cruzar de vuelta con ese software que se llama Maxent y tratar de ver qué resultados nuevos nos arrojan ya ahora en este momento que estamos ya como país libre de malaria, ¿verdad? No sé si esa es la respuesta que buscaba, pero esperemos publicar rápido para que vean también más detalles. No obstante, si quiere después contactamos y le doy más información también. Pero se llama Maxent. Gracias.
Thank you. If there are no other questions, I do not see anyone approaching. I would like to end this session. Thank you very much for your presence.
Esse primeiro dia de apresentações orais. Nós teremos 5 apresentações, né? Os apresentadores terão 7 minutos de apresentação e nós abriremos para uma pergunta, tá bom? De 3 minutos. Então, a primeira apresentação será da Yasmin da Silva Santos. Por gentileza, Yasmin, você tem 7 minutos.
Bom, primeiramente, boa tarde a todos. Mas acho que não precisa, não. Boa tarde a todos. Eu me chamo Yasmin da Silva Santos e hoje eu vou apresentar o trabalho intitulado Comparative Study of Respiratory Parameters in Acute Respiratory Distress, Syndrome Associated with Malaria and COVID-19. O grupo declara não ter conflitos de interesse. Bom, a síndrome respiratória aguda, ou ARDS, é caracterizada por inflamação pulmonar.
Is caused by an inflammation, pulmonary inflammation, and leading to hypoxia, and so malaria and COVID-19 might cause this. So our work aims to analyze the pulmonary capacity of these animals. So 2 murine models were used in the laboratory. One of them is DBA2 in the transgenic model infected with SARS-CoV-2. These animals were submitted to a scan of the entire body, and this technique has no need for contention and anesthetics of the animal. So it reduces the animal stress, and they, as represented in the second photo, there's no need of contention. And this machine captures the differences of pressure inside the chamber, and these data are sent to a software, and this upper image shows how this parameter is got and how they are reported. So for the presentation, for today's presentation, I have 5 parameters for discussion. The first one is the respiratory cycles per minute, and in the infected group with malaria, described as BDA2 plus BDA. And in the COVID-19 group, we had a decrease of the respiratory rate of these animals. So the EF50, which would be the volume that was inspired, and the respiratory peaks were caused by malaria. And there's the bronchoconstriction rates in the second graph. So the infected group with COVID-19 showed the biggest reduction. So these results show other results that we had with the histopathology in the malaria cases, in which the respiratory rates are decreased, in gray areas with inflammations shown in the histopathology, showing that the constriction index shown in COVID-19 is derived from an inflammatory process great inflammatory process. And there is an analysis of correlation that showed that in malaria, the rate of ventilation was associated to the periods of expiration and inspiration. And in COVID-19, the reduction of respiratory rate, shown that this might be a compensatory rate flex. So malaria and COVID-19 reduced the pulmonary capacity in those animals. And besides that, this method is a technique that allows the accompaniment in real time of these animals on a daily basis, making able to look at different mirroring methods. So here I leave my contact. If you have any doubts, you can send me an email. So we have time for one question, brief question. If anyone wants to ask a question. So thank you, Yasmin, for your presentation. Second speaker will be Dr. Simone Ladeia. Please. So the topic's going to change a little. We'll talk about vectors. There's an evaluation of susceptibility of populations of Sterlingi in the area of Bacillus and insecticides. So very little has been demonstrated about the correlation between resistance to insecticides. In Brazil, there are two studies registered in WHO, one in Pará, which shows the susceptibility, and one in Acre, showing a possible resistance. The study was made in Barcelos, which is in the region of Rio Negro, which is a place with indigenous communities, and with an intense use of pyrethroides insecticides. So the objective was to evaluate the susceptibility to pyrethroids, insecticides, and the possibility of the use of another insecticide. So I will go on here. This is Barcelos. So we had did a study with impregnated paper made available by WHO. Something has happened here. I guess there's a problem here. So please take a look at my time. Okay, so there's the impregnated paper. Not go into more details. But there is a decrease in the keynote down in mortality in 24 hours. So we did a study from 2014 to 2016 in female captured in the standard information that we had at the time. So we had 5 samples in the urban area of Barcelos and compared with the rural areas in which we didn't have a lot of insecticides being used. And in 2024, we did a bioassay in laboratories and in urban areas. There was in the lab of FIOCRUZ in Rio de Janeiro, and with which is nicotine. Well, the bioassays, there weren't patterns. We did an essay by dose response. It was made by this student here. So the conclusions were that we had susceptibility. Those that were 98% susceptible, the ones that were susceptible were had a death rate of 98%. So it is an insecticide that is slow speed action. We evaluated the mechanisms of resistance. So we had ancient samples, old samples, and we made bioassays to evaluate the metabolic resistance using a synergist PBO showing possible use of oxygenagens. So there is we compared rural areas and urban areas. So we had 100% of mortality in the two rural areas and a mortality of 78.7% in the urban area of Barcelos. So this was a significant comparison, and we had female that were captured. So in 2024, we made a study with the F1, and we did this in the urban area and in rural areas again. And what we had of mortality of rate was 67%, and we had an exposure for 2 hours to insecticide, and there was no enough mortality to consider it as susceptible. And this was made in optimal conditions in the laboratory. And this is the mean that happened in the rural areas, but also the result was worse because the rate of mortality was 58%. For delta methina was
44.2 mortality for ethofenprox, and even worse for spimetrine, which was 26.6% of the mosquitoes, showing clear resistance to the urban area of Barcelos. The summary of the mortalities in field and in the lab in great conditions. We did not find any mutations in the KDR in the mosquitoes in 14, 15, and 16, and the assessment so we decided that it was a reduction of the susceptibility, and when we exposed to the PBO and deltametrine, where we had mortality of only 68%, we reached 100% in 35 minutes in the exposure of PBO. The same observation with the ethofenprox, which had mortality of 44%, and we reached 100% in 1 hour, and also with alpha spimetrine, which we had the worst result in terms of resistance and showing the restitution of between 30 to 40 minutes. Now confirming the resistance to pyrethroids and that the resistance is a metabolic way. In the SumShield evaluation in non-nicotinoid with another focus of action, we verified the susceptibility with 98% up to 72 hours. So we reached the mortality of 100% within 48 hours. So for ShimShield, this is susceptibility. So the conclusions is that we have resistance to pyrethroids in the urban area of Barcelos, which might be compromising the vectorial and the resistance in the urban area. I didn't mention, but the collection was all the extension of the area. And the resistance of the metabolic type, which probably is mediated by monooxygenases. There's no CODR modifications. In the analysis, we verified that we did not highlight that there are. We have susceptibility to SumShield, but we verified 48 hours in the lab, and this beneficial must be discussed. I really thank the people who helped me develop this study. Thank you. Does anyone have a question? Okay, thank you, Simone. For the third speaker, Andrea Luciana Soares da Silva. Well, good afternoon, everyone. My name is Andrea Luciana Soares da Silva, and I will show my work titled Adaptation of Amplification Techniques of Nucleic Acids to a Portable Platform of Lateral Fluid for the Malaria Diagnosis. So I have no conflict of interest in this work. This work is a postdoctoral project in partnership with the Lisbon Center. I am supervised by Ana Paula Arezi and Marta Medeiros, and this is former work which I was invited for optimization of this technique. So we know that malaria is a parasite disease with a lot of mortality in the African continent, being one of the main reached by this disease in the last years, with techniques associated to the diagnosis in microchips or chips that attempt a diagnostic process that is faster and more efficient, making that an important tool for diagnosing malaria, both in the endemic environments and also in low income and also in non-endemic areas. Besides being a fast, accessible, and sensitive diagnosis, and having the presence of the biomarkers which have the marking in these dispositives. So the goal for this study aims to develop a protocol for the molecular diagnosis of malaria adapted to a portable platform and the lateral flow to be used in the surveillance, the routine surveillance or detection of occasional outbreaks with Plasmodium vivax and Plasmodium falciparum. And this study, we have samplings of DNAs of falciparus samples, which are cultivated in the tropical hygiene lab, and patients that were infected by the other types of Plasmodium. So we have the primes in extremity 5, line 4, with oxygenin for falciparum and biotin for vivrae Plasmodium. This reading of this is in a stripe with biotin and one NACODE and oxygenin, and the reverse, which is done with fix, is associated to a gold particle where we have a reaction that would be done with the presence or not if this individual is with falciparum according to what's marked. So firstly, we have a PCR step. So we had a simple PCR for the detection of a unique species of vivae and falciparum Plasmodium, and then we have a stripe for the observation. So the stripe, we add the stripe in a reagent with the result of this product of PCR amplified, and we have the observation of the markation. Firstly, we had a simple PCR using DNA with a concentration of 1 nanogram per liter of Vivax Plasmodium. We had E-gen primes from the species and then we had 2% to analyze the molecular weight. For our surprise, what happened was that the samples from negative control that have no presence of the DNA on the parasite, we have the stripes showing as if inside that tube we had Plasmodium vivax samples. When we had falciparum Plasmodium, same thing happened. So both in the sampling and positive control and negative control, we have reactivity in the stripes. Then We had a PCR test for multiplex. We separated. We had a multiplex PCR and we separated the one of the tubes. We had vivac samples and for separate sample, but the primes were together. So the primes are set both with biotin and oxygenin and stripes, and it's happening the same. So we have the presence of negative control. And this suggests and makes us think that we are having a process of unspecific connection of the marcations of these primers in the prefabricated stripe. And this can happen due to many factors. So the results can show that we have a sensitivity. It is but it's not too specific once the negative control is not reacting without the presence of DNA. So the reactional mix, both in the multiplex and the PCRs5, shows the unspecific connections. One of the possibilities can be the formation of the diminishing of primes or the presence of herpes and the Chlorophyll presence. Um, it's more unstable when you have temperature variations of the fun chlorophylls, where we can have the primes. This is why in the first moment we had the prime with fun prime with chlorophyll prime to verify if this is a chlorophyll making these unspecific reactions happen so that we can optimize and test afterwards that significantly adapted to congratulations on your work with Erica Braga from UNLV. I have a doubt. I'm not sure if I didn't notice, but the purpose is that you have a quick test, but that previously you can have a PCR. Is that it? Yes. And when I got to the Institute for the standardization, they had already tested many techniques. They had tried LAMP. They said LAMP didn't have any sensitivity. They had a simple PCR and a multiplex PCR, but from the point where you already have a PCR involved in the system, we eliminate the quick test. And in this case, yeah, that's my point. If you need previously a PCR, what would be the application? Yes, the only thing we can eliminate in this phase would be the visualization in GeoGebra rows. That in this point, this is the only thing we can eliminate in this first moment, just the visualization of this. So the manipulation would be lower, but the cycling steps we would need. And my next attempt would be to try again to go back to LAMP because I think it's a simpler reaction and more uniform. So there's no different variations of temperatures. Thank you. Thank you, Andrea. Thank you, Erica, for your question. Next speaker is Rebecca Shukri Souza. Good afternoon. My work themes malaria transmission in the state of Pará, Brazil. I declare there is no conflict of interest regarding this presentation. Malaria is a disease that, as you can see from the WMO report, and you had 20 million cases and 68,000 deaths in Brazil, in 131 cases in Brazil and 62 deaths. When you look at Brazil, you can see that this is endemic in the Amazonian region. And in 2022, we had municipalities that have malaria. As you can see in the risk map that came from the where you see that most municipalities with risk were in the Amazonian region and some municipalities were outside the Amazonian region with risk. The risk classification was done with the parasite with IPA. As you can see, you classify by the transmission up to high risk, and that's important for the national control for malaria when they classify with risk and for each municipality. This national program is under the supervision of the Health Ministry. The Brazilian legislation regulates some laws, and they also regularize the malaria control management, which is necessary to be created for environmental licensing in endemic areas. And big construction as power plants, they need environmental licensing. So in endemic areas, they must have the control, the malaria control measurements, because these big constructions can cause changes in the environment that could cause the raise in cases. And then we have entomological studies before and after the building, which includes the potential evaluation done before the construction to define which municipalities need action for the disease control. And inside the selections for cases control, we have the diagnosis and treatment, but also the monitoring for malaria in the endemic region, which is done due to the etymological studies. And we have the vector controls, including the insecticides, spraying, and etc. With that, the goal of our work is to analyze the malaria transmission in the direct transmission in Belo Monte in state of Pará. For that, we've observed the municipalities affected by the Belo Monte power plant. As you can see, are 5 cities. After the assessment, we have Altamira, Napu, Vitória do Xingu, and Senador Porfírio. And after that, we have the data for parasites and also the number of mosquitoes and infected mosquitoes. And the IPA, we have the malaria and the number of mosquitoes for the entomology for the Evandro Chagas Institute. You can see a graph where IPA is shown through the years. As you can see in the building process, there's a very abrupt fall, and since 2014, all the municipalities were classified as low risk or very low risk, and it stayed until 2024. Here we have the rate of mosquitoes through the years, and as you can see in the building process, we had a big fall. And since 2013, we started capturing less than 100 mosquitoes by trip, and then the mosquitoes rate that were infected showed in periods, and the rate in the pre-construction was 3.38, 1.98 in the building, and after the construction, this was 0. When we had the testing, we had a significant change in APA when pre-construction was compared. The significant differences between the pre-construction and post-construction, this was a significant fall because as we can see in the graphs, this was a fall in the construction, especially the significant difference between pre-construction and post-construction. This is explained by vector control and malaria controls that were done following what was described in the Ministry of Health and Brazilian legislation, and we had the action of malaria control by Norte Energia in the Belo Monte power plant, and what is described in legislation to be able to control the disease that is said. There was a correlation between the Anopheles mosquitoes and IPA, and the number was 32% influence in IPA. When you have this influence, we think that other factors have influence in IPA as the disease control, but the building of Belo Monte power plant affected the transmission of the disease, and we found a correlation in the two municipalities that are distant and less affected by the building. As you can see, this was according to the Indigenous Council, and this correlation wasn't found in the two closest municipalities in Belo Monte, which were Altamira and Vitória do Xingu, and they were affected by the building. So we believe that the construction affected the transmission in this manner. With that, we conclude that the malaria was affected in this region, as you can see in the amount of mosquitoes, and also the fall in IPA, the amount of mosquitoes in post-construction, which is also explained by the control of the diseases and the vectors and disease, and this was established by law as the power plant of Belo Monte in the endemic areas of malaria, which is important to follow what is described because it helps controlling the disease in endemic regions. I'd like to thank all the participants and the institutions, especially the entomology of malaria lab. Thank you so much, Rebecca. Does anyone have a question? Now we invite the last panelist, Jamile Gregorio Dombrowski. Good afternoon, everyone. Thank you so much for your presence. My name is Jamile Dombrowski, and I will show some previous results of the project we've been developing about the studies of genetic sequencing focusing in the Plasmodium falciparum using the technology of opsin nanopore for the sequencing. We declare not having any conflict of interest. And the resistance to the anti-malarian medication is a long problem and a global challenge that is established. Though recently, some falciparum plasmodium resistant to artemisinin, which is our first-line medication for malaria treatment, they came in the southeast of Asia. You can see the region with red dots, and they are disseminating quickly all over the world. So there are many reports in the African continent. And in South America, we also have reports in the Guianas of existing. In Brazil, we still don't have a lot of genomic studies assessing this resistance part, and these studies that we have, they have reduced numbers. So we have a lot of challenges as the borders extension, economic challenges, political challenges, and environmental challenges. Also, the growing number of malaria cases that we've been reported in the last years. When we talk about malaria cases, you can see in the graph the blue line shows the 2022 data, and for 2023, in the green line, we had the adding of almost 10% of the malaria cases. When we focus only in the Plasmodium falciparum infections, these data are even more alarming. Basically, all the legal Amazon states have Plasmodium falciparum cases. And we know this process of acquisition of resistance to the medication is very complex, but the mutations that are specific, they're key point for the development of this resistance. So the genomic studies in large scale come as funda fundamental strategies for foreseeing and improving the malaria control, focusing on the elimination. Having said that, we have this project, this pilot project. So we use samplings of two studies, one done in 2013 to 2014, and some other done more recently in 2020 and 2021. They were both done in the Juruá region in the state of Acre, and so far we are using this panel with 5 genes published last year. Cambridge group developed, so we standardized it according to our reality in Brazil, since we have low parasitemia, and we are optimizing the protocol so that we can use that in large scale. So during the PCR, we added in the primer a specific barcode. So at the end, we can unify those plagues and what benefits we have. We reduce time and especially the cost for the sequencing, which is really bad for when we talk about this type of technique. So after PCR, we can get this plate and follow the sequencing, which currently we are using the off-Stanopore platform, especially Manayo, because it's portable and we can follow the sequencing in real time. And for the analysis, we're using the Malaria Profiler, which is a software of open access, recently published by our group of research. We can have access to the manuscript. We have two versions. To be analyzed, and in the future, we intend to translate that to Portuguese, and then we can implement this with the government and the ministries to disseminate this in all the Amazonian region. And in this software, we're able to analyze both the complete genome of the parasites and also the ampicons. And what we have as results so far, using these samples of the two periods, we found the mutations you can see in the graph, in the bar graph, and all of those with a bigger frequency of 80%. And when we associate these mutations with the medications, we associate more than 90% of our sampling showing the triple mutation in CRT and MDR1, and this is associated to the chloroquine resistance. We expected this because we know that this is a mutation fixed in the circulating species in Brazil. Besides that, we also find a frequency of 81.6% with the mutation named DHFR, and that means the resistance to pyrimethamine, as well as a raise in 91.6% in the mutation triple in DHPS associated to sulfadoxin. And when we separate this by period to assess the genetic variation of the parasite after a few years, what we observed was a reduction in the triple mutation in CRT and double mutations and unique mutation, and similarly to other drugs. So we had a reduction of the mutation of DHFR of 69%, as well as sulfadoxin as a reduction of 62 in the double mutation. These are previous data that we are acquiring, but they're very interesting and important to have this in mind of the large-scale studies and also for monitoring of the resistant circulating species in our country. I'd like to thank my group of research from São Paulo on the name of Professor Cláudio Marinho in the Biomedical Institution of USP, and my of research in London School under the name of Zana Campino and Landy Clark and all the collaborators. Thank you so much. Thank you, Jamile. I can see Alexandre is already here for the question. Thank you, Jamile. It's good to know about Vale do Juruá. I really like this place. I'm trying to understand what is the applicability, practical applicability of the results. The falciparum, you base this in ACT, and we discussed a lot about the emergence, as you said, in the introduction of K13, and you're showing chloroquine, which are drugs that we use for treating the falciparum malaria. Can you add the context of the applicability and the use of that? Thank you. Well, thank you, Alexandre. That's an excellent question. So far, we're still using the panel. We tried it for K13. We did not detect that. I only showed the data of Vale do Juruá, but we are in a collaborative network investigating this in many other states and many other municipalities. We haven't found it to K13, but the idea is for us to broaden this and use this for drugs that are currently circulating in our country. So the idea is to optimize regarding cost for the genetic sequencing and to broaden the genomic network in the states of the legal Amazons. So it is a pilot project, but the idea as a public policy is to broaden the panel and optimize the cost of sequencing. Thank you. Thank you, Jamile. Guys, thank you so much for your presence. You guys are not hungry, so you have been here for your colleagues, and the coordination said that we will return at 1:35. So have a great lunch if you are able to.
Let's go back. You have to sign your attendance list. At this moment, we will begin our roundtable, Malaria in special areas of Brazil. We invite researcher of Evandro Chagas Institute, Tanya, to act as moderator, the coordinator of elimination of malaria and transmissible diseases of the surveillance secretary of the Ministry of Health, Pablo Sacato Fontoura. Good afternoon, everyone. Thank you very much. We'll have to accelerate a bit because we lost some time, and we will invite everybody to compose the table so that they can sit here together with us, and so we can continue our activities. She's a doctor epidemiologist of Oswaldo Cruz Institute in Rio de Janeiro, and she will talk to us about the scenario of malaria in mining areas, proposals to diminish the charge of the disease. So I invite also Dr. Alexander, who is our coordinator of the malaria control program, and he will present to us the implementation of Penoquina. And I also invite Dr. Mauro from the Tropical Diseases Institute of Rondônia, so that we can present the participatory program by the communities and the implementation of it in special areas. So Marta is our first speaker. Thank you, Marta. Thank you. Good afternoon. Are you listening to me well? Yeah, so at first I'd like to thank Giselle and organizers thank you for the presentation. So we will talk about the scenario of the malaria in mining areas and proposals of action to decrease the charge of the disease. There's no conflict of interest, so some definitions are necessary. So first, what does it mean? What is mining? What does mining mean? So it's defined as an individual or organized group work using basic instruments, manual tools, or portable machines. Illegal mining is referred to all unauthorized mining activities, including both artisanal and gold mining. It's not only gold, we have other kinds of minerals as well. Approximately 90% of illegal mining is related to gold mining in the territories. And normally, there are limited economic resources, restricted access to healthcare in mining and non-mining areas. There's the capital lead people to traffic the minerals. And normally these activities work in places with drug trafficking and violence and other crimes. So here is the Pablo Amaral work showing how mining has increased in the last few years, 45 years. I don't know if I can see it here. Here in blue, you can see legal mining, and in red, illegal mining. So it's been increasing the last few years. And fundamentally, illegal mining, it has increased in the last few years. We have also this work of the RADMA group showing points of illegal mining in the Panamazon area. So we have almost 500 places identified where we have illegal mining. 87% are in active exploration phase, and more than 50% happens in Brazil. And more than 30% of these areas are suffering a very high pressure, are making a high pressure on the environment. There's a negative highlight for Brazil, Ecuador, and Venezuela. We have territories that are very heterogeneous. It depends on the location, size of the mines, and we also have to understand this context so that we can understand that some areas are legal, others illegal. A lot of them are connected to crimes and actually organized crime. We have a high mobility of the workers, and it depends a lot on the regulation, on every country's regulation. What we know is that in 2022, 90% of the area mined in Brazil was concentrated in the Amazon region, and the illegal mining was the major mining activity in the count of gold mining in the country. The number of mining activities in Brazil has recently increased the last few years, and 40% of these mined areas from 1985 to 2022, there was an increase in this illegal mining. 62% of these illegal activities happen in indigenous areas, and it covers 442,000 hectares, and it has increased in the illegal activities have increased in 173%, and the legal mining has increased in 40% in Brazil. So in this heterogeneous context, the idea was to understand what are like these illegal areas in Brazil. So we have rural areas that have no environmental protection. For example, they happen in national parks, and the mining in indigenous areas and in transborder areas. So we have to think about that for control and elimination. So mining happens in non-protected areas, and we could see that the deforestation in those areas have increased in 20%. In indigenous areas in 2021, the area of illegal mining was 102% higher than in 2018. And we can see that the deforested areas here in this graph, the last 5 years, well, we have another problem, which is mining in the border areas. So this is an image of Madre de Deus between Bolivia, Peru, and a bit in Brazil. Here we have a gray context in the last few years, that this illegal mining happened in these countries: French Guiana, Suriname, Guyana, a part of Venezuela, northern Brazil, and a part of Colombia. And these are the most ancient areas of the world, and we have more illegal mining activities here. So people that live in these areas are fundamentally male, 80%. They are young, between 15 to 29 years old. They live in very remote areas of difficult access. They live in irregular situations. They go to other countries. And sometimes they live in Brazil, but they are working in conservation units, for example. There is a low educational level. There are various risks, for example, exposure to alcohol consumption, unsafe sexual practices, exposure to mercury, among others. There is a high social vulnerability, and in recent years, criminal organizations have arrived in those areas, especially in northern Brazil. So these are the 4 factors that are very important for variables: extreme distance, mobility, clandestinity, and they are responsible for the transmission of the vectors. So in this context, we'll talk about the scenario of malaria. So there are 5 areas where the Ministry of Health works with. So the mining has increased in the period of 2 years, and not all cases are in the same situation, so we have to understand each context. For example, we can see here in Roraima, 40% is due to mining, and in Pará, 29%, Amapá, 16%. And in all of those states, we have these levels of illegal mining. And we can see that in the Amazon area, 8.6% of the cases are related to illegal mining. And in the extra Amazon region, we have another number here. So in the Amazon region, the area that varies in regard with the location. So the industrial legal mining was 22 times higher than in the places where we have legal mining. So if we have illegal mining in the area, the risk is increased. So 58,000 cases are related to mining, and they came from outside Brazil, from French Guiana, Venezuela, and Guyana. But this situation is changing. There's Francisco here who has been doing a work. For example, we have cases in Maranhão. So there are people coming from other places from Brazil. There's this map from Pablo Amaral showing, as you can see, there are dots, and these are showing migration zones here. So there's migration among sites in Brazil. So in the last 2 years, there was a decrease There was a decrease in the cases of malaria in Brazil, but then we had an increase again. When we evaluate 2023 and 2024, we had more cases, and these are data that come from the Ministry of Health. So most of the cases in those areas happen because they work in exposed areas. So the house of a worker it's not a house actually, it's like seen in the picture. So they are very much exposed, and they rarely use bed nets unless we have campaigns of education. So they say that it's not comfortable. Sometimes they have to run away from the police, and so they don't like to use the bed nets. Okay. So what we know is that there is a high positive correlation between illegal mining and malaria. It has emerged as an anthropogenic action that is very important, especially in indigenous areas. And we have a correlation of more than 20%. So there is difficult to access health services. There's no parasitological diagnosis. The epidemiological surveillance is very precarious in this population. There's little coordination between countries. There's a high self-medication with antimalarials, and they are smugged most of the time. There is no low adherence to adequate treatment, and it can lead to resistance to antimalarials. So these are the questions. What strategies can we adopt? So there is in the work of Pablo Amaral, they point to 5 problems. So there is the administrative status of the mines. It's important. The remoteness and accessibility of the mining camps. The political, economic, and security contexts. The robustness of the care system. The national regulatory issues. So until a few years ago, we had a government that wanted to have illegal mining and the environmental protection strategy. So we need responses that might be fit in each context to diminish the cases of malaria. So there are 5 strategies to reduce malaria. So first, we have to control deforestation and avoid the illegal activities, to strengthen the network of surveillance, especially with the professionals of health, and so that we can support the treatment and diagnostics, reinforce the vectorial strategies that are necessary, and to integrate deforestation alerts into the malaria program. So each time more, we have to pursue a unique approach to the people. And these strategies cannot be implemented uniformly. So we need innovative strategies and tailored specifically with the context. And so if we think about the 3 great groups of mining, we could think about mining in protected areas, such as indigenous parks and so others. This intrusion, so we cannot think about a protected area with mining. And then we need to remove the people that are in the areas, especially those that are in the indigenous lands. Otherwise, the unprotected rural areas, for those we need strategies to promote wide testing, community agents, health agents, and voluntary people that might control and make treatment of malaria. We have to think about strategies for the asymptomatic infections, And we need to have epidemiological surveillance of and evaluation of actions. So we can see the difficulties we have. So there is a place here, Causuene, in Amapá. So people have a lot of difficulty to get to that area, for example. So another important thing is to have microscopy, case detection of malaria by active search and aggressive, frequently, from 1 to 3 months. Visit the mines. It's not easy to get there, but it's possible to go. And also, it's important to have impregnated bed nets and also education. We need microscopists. It's not very easy, but it's important. There's the case of Madre de Deus, which is in the border of Peru and Bolivia. And we applied drugs massively, and we could start to think which were the best ones. And here is in Suriname. So they could eliminate malaria. That was a very successful case. And so they could do it with the help of health agents, and they could do treatment afterwards. And there's also the Malakit project, which is a new strategy to think about this exceptional situation, to apply these in exceptional responses. So there's the Malakit made with an international partnership among French Guyana, Suriname, and Brazil. And there's also free distribution of kits, 8 kits, and they are free. And there's also for treatment. And also it's a strategy of education. So they learn to use the tests, and they can use in the mining places. So in 2020, there's the distribution of the Malakit. Here is in this, we have the PERS to avoid it getting wet. And we have 3 rapid tests. And a result was that we had a project with an evaluation with a broad variation. There was a pre-evaluation, a post-evaluation, a qualitative research with the accompaniment of time. And we could deliver almost, give away almost 5,000 kits. There were 71% of the people used it correctly, and there was the implementation of people that made the tests before and after using this kit. There's the prevalence in general and the prevalence for falciparum. And here's the reduction of malaria. And there's the Malakit. So the strategy was broadly adapted in Suriname, so as one of the tools for control of malaria in that area.
Currently, we also had in July this year, which was very complex because we have a regulation, and in Brazil, we have a ministry that probably can be implemented as a strategy. The lessons learned for this. So all the articles that were published during the project, that we thought better how we can have the strategy. And one thing that is fundamental in this project, that the health agents, people in the community that learn to perform the tests, to deliver the kits, and follow the project. Not it has to be people in the community. And in the project that were very good for the falciparas, but to control the disease, but they were not able to control the new cases because we didn't use the permacan. So the possible complex treatment. So currently we are working in the Corema project. We have all the partners in French Guiana and Suriname. We are almost finishing the interventional phase. In December this year, we're starting the quantitative analysis and the qualitative assessment. We have the result of this project next year to understand how much this project can be used as a tool for the control of malaria. What is fundamental for this project is the cooperation for the monitoring and response for these problems. And here, we would like to propose a necessity of a regional cooperation, which was done in Asia and Africa also for the control and elimination of malaria. So we said that in the presentation about the need to do it all together. If one country eliminates malaria, but the rest of the countries is not able to do this in this context, we will always have the risk of reintroduction. So it must work in a context of regional cooperation. We have problems with fragility of the local systems and the limitations of funds and the lack of implementations of different policies. We can sit and talk for the elimination of the malaria. And this regional initiative for the control of malaria and the cooperation for eliminating malaria in this context, thinking about we can have the Secretariat in PAHO, OPA, or other organizations. And we have many challenges, but we have many strategies coming recently, both scientific and communities, that lead us into thinking that we will be able to control and eliminate the malaria in this context. And what we thought a lot about is that together we can end malaria. Scientists, managers, and community in a work that will be done only by the government or science or communities. It's together we can end malaria. Thank you so much. Thank you so much, Dr. Marta, for the excellent talk. I'd like to invite our second panelist, Alexander Vargas, who's a coordinator of the Coordination for Elimination of Malaria in the Ministry of Health. Good afternoon. After lunch is a little more complicated, but let's do it. I would like to appreciate the opportunity once again. Dr. Giselle invited us, and the idea is to talk about tafenoquine and the implementation of tafenoquine and try to have all the relations with the malaria areas. So we will discuss a little bit. Some of the slides were already shown by Dr. Alda, so I'll be very quick through them. We do not have any conflict of interest. So now, going through with our elimination plan of the malaria, we want to eliminate malaria up to 2035 in Brazil. This is an historical series well known by the majority of us, and we just call your attention to the decade of from 50 to the 60s. Malaria would occur in Brazil from the 80s. It was in the Amazonian regions, but this was diminishing, as we can observe in the Amazonian region and also in some municipalities with a bigger amount. So this is important because we define the areas, that the specific areas. And now I'm provoking to all of you, and something that we want to discuss internally in the coordination for the elimination of malaria that we share in a didactic way. But I think it's important for us to, in short term and long term, to start discussing. When you say rural areas, we have places like Rondônia that you can get there in a truck. In the rural areas in Marajó Island, which is a place I'm not really familiar, I think we must talk about it in a different way. About the settlements. Some settlements are programmed or planned, but some other settlements are done differently. So we must discuss better about this approach. Also the illegal mining areas. As Dr. Marta showed, we have legal mining, which should be the minority, and we have the illegal mining. And now, in the indigenous areas, we have had the opportunity to investigate these different areas. We've been to the Yanomami territory, and this is something different. You can only get there by small airplanes, so the approach must be different. So here, this is something that caught our attention. We are producing another note with our colleagues from CIMAS with a very big worry that with what's been happening this year, especially in Roraima. And that is worrying. When we go to Roraima, our colleagues say that 30 years ago, the disintrusion process that was done by the army was done, you tested and then you treated people, and currently this is not happening. So what I see here is that we must understand that this is also a matter of public policies, and many people who are there are victims. This note calls our attention for states like Maranhão, Tocantins, Mato Grosso, with the possibility of the arrival of people with malaria. Once again, the division by areas, and now showing that in 2024, I'm talking about tafenoquine, we have acquired almost 37,000 pills of tafenoquine, and this is being used. And we will show this ahead, and we have acquired 206,000 pills of tafenoquine for us to implement in other areas in Brazil. This is the informative note that we had for the usage of tafenoquine and the materials we have for the implementation of the S6PD. We also use these moments for guidance, for notifications. We also talk about the harmful malaria. What we've been doing with tafenoquine in Brazil, the patient must be positive for Vivex malaria. And from then on, the person has this test performed G6PD. If it's above 6.1, this person can take tafenoquine. Between 4 and 6, it's an activity that we classify as intermediate. They will have 3 days of chloroquine and 4 days of tafenoquine. If it's under 4, they'll have 3 days of chloroquine and 3 days of tafenoquine. Currently, where we cannot use tafenoquine is people under 16 years old cannot use. Less than 35 kilos, women who are pregnant, breastfeeding, people who are under 6.1 cannot. We also do not use the tafenoquine for serious malaria. With the pediatric difenaquine advancement, we will change this a lot, and we will change our target. So in this implementation, in the training, in the municipalities that so this is the articulation between the Coordination for Elimination of Malaria, and we really appreciate the trust team, Dr. Marcos Lacerda, the guys in Trust Foundation, have been helping us a lot in the training, and the states and municipalities have been great partners. We have many of them who are partners, and I consider this to be successful. How can we perform trainings? After March, it's about 6 or 7 months, we have been improving, and we've reached a situation which we consider ideal. So on average, we train 50 people per municipality and many health professionals, community agents, endemic agents, doctors, pharmacists, nutritionists. So we have many people participating in training. We have reached, in the morning we have the theoretical phase and the practical phase. And in the afternoon, we usually take a doctor who will talk about serious malaria, non-serious malaria. And besides training the S6PD and implementing tafenoquine, we have been strengthening the surveillance of malaria and the treatment. And we have had a lot of doubts, and this is something very important. Another important point is telemal, which is a teleconsultancy where doctors with nurses have the questions from the health professionals in the further regions. And many, many times in our speeches, they call and send messages to test if telemal is working. And this is good. Telemal has many videos which help us in S6PD and doubts and the trainings. We have had trainings in many cities. In Jacarecanga, we have started in the Yanomami territory, in Boa Vista, Manaus, in Barcelos, Santa Isabel do Rio Negro. So in 2024, we have trained about 1,531 professionals in many cities. But now we are a little more ready. We have analyzers, stripes, and tafenoquine. And as we started initially, we had some difficulties, but currently we are a little more well-planned. And in 2024, we have another 2 trainings that we will perform in Jamari, Guajará-Mirim, Rondônia, and New Mamoré, and we are also planning one for Tefe. We will also implement in December. And here, our planning for the year of 2025. In the year of 2025, we intend to expand for the municipalities we consider priority. We have the biggest global rate of the disease. We intend to close the state of Roraima and the state of Amapá. And we also intend next year, I'm not sure, Dr. Cláudio is here, we intend to have a meeting of Extra Amazon and then train all the vigilances to implement the tafenoquine in the Amazonian region. We understand that this is something important, even though we don't have the big load, but it's important for us to have this in the Amazonian region. So next year we intend to raise a lot. We have more than 150 professionals, and we also have analyzers and tafenoquine for this. This is just to show you in 2024 and 2025. And how have we been doing this implementation training? We're learning, so our technicians and our colleagues in coordination together with the guys in the tropical medicine in trust have been helping. We will publish this afterwards, but this picture, I believe it's in Jacareacanga or Itaituba. It's a very interesting photo in Tafenoquén. Just for you to have an idea, this number must have changed. 2,106, yes, we have a delay in CSAX in malaria, but Manaus is the city where we have the biggest number of treated people with Tafenoquén, with Porto Velho, which what we expect because they're capitals, but now we have São Gabriel da Cachoeira. We have implemented there not 2 months ago, and we have a lot of people treated. It's one of the biggest loads in Brazil, and my colleague Pablo Amaral is the second biggest indigenous municipality in Brazil. Is that correct? Itaituba also was implemented in about 2 months, 171. Calçoene is been going well. He's got a lot of criteria and less inconsistencies. And from this 2,100, this number must be in 200, 300. So we have about, when we had this test and it was positive for Vivax, we have about 7% which have lower activity. And the intermediate, it's about 28%. And this rate of 4 and 6 is where we want to have a study so that we raise our range and that they can use the Tafenoquén. So we really raised the bar here as a safety measure, but this is what we are planning to study and revise. So here we have a few of the analysis that we have had with CVEP, and we have very little inconsistencies, and it can happen for, it could be inconsistent to maybe a typo. We are working with the trust colleagues, and then we will publicize this. And what were the main challenges we found for this implementation? Adding innovation is always complex, especially in large scale. People, us humans, we don't really like changes, but we have been observing this to be very positive. Cases treated with eligibility criteria, in many cases, people are very confused and they prefer the Primaquine. But in doubt, use Primaquine. A lack of insumes in the beginning of the process. So we have had a lot of success. We really appreciate the Department of Pharmacy in the ministry, the Industrial Complex Secretariat, because it really helped us, the understanding of the professionals in the use of Tafenoquine as possible. So a lot of people don't want this change. I'm becoming more experienced, and people who are more experienced, they have sort of some difficulty, but this has been good. The acceptance of the population is great, and the Brazilian people, I have had an experience to go into many places. Um, well, they don't like it in the beginning, but they are good people, so they understand that we are playing our role. The lessons learned, we noticed that from the beginning to today, we improved our methodology and we apply at the end of the training a questionnaire to assess if the people who are being trained, if they have learned. So we changed our methodology. We added classes of in the morning, we had a malaria class for the afternoon.
And we noticed that it's about learning, it's management of assets, so to supply the chain. So our colleagues have the control of how we can or cannot liberate the phenocryptine and the devices that and make the analysis. So it's something to learn about, and we have observed that there we strengthen things. So For example, in the case of severe malaria cases, the treatment of phenaquine has helped us to solve these questions, so this was very important. And also closeness with the local groups, so I could get to know coordinators and people. So this has narrowed the relationship with the cities and with the people. Also integration, as I said, it's fundamental, and we have been working to have the pharmaceuticals surveillance. So we are using these databases. There's the CVEP, for example. We are going to cross the data, and the trust people are helping us, and we are going to try to detect severe cases, but until now we haven't had any problems. So what are the perspectives finishing things? So the implementation is being followed by age. So until 2026, we are expecting to have this. We want to strengthen this training about severe cases, and we know that in the Amazon region we have more severe cases, and so we think HS and MMV, and maybe until December we will finish the cost-effective processes, and I hope that next year we can purchase the pediatric sulfanoquine. So the demographics is very clear for us. 40% of the people are kids. So in the future, we want to have to make studies, and we want to support studies of researchers for unique cases and other drugs. So we want to facilitate treatment, but also based on scientific evidence. And that's it. Last year we had a celebration, and this is a picture here, a photo that was taken in Barcelos. And here are some people of our team of coordination of malaria. We have now 31 supporters, which are people that work with us in other places. So are we going to eliminate the malaria? That's a question for you. Thank you. Thank you, Dr. Alexander, for your presentation and for presenting the challenges for us in the implementation of phenaquine. Now I invite Mauro Tada, and he's a doctor, and he has founded the Institute of Malaria in Guaporé, and now it's in Porto Velho, and he's the director of the Tropical Medicine Institute, and he's also the director of, he's also a consultant of the Ministry of Health, and he coordinates the plan for elimination of malaria in Rondônia. So he will talk to us about the participatory planning and participation of academia and state in some areas. Good afternoon, everyone. In my case, our presentation is a little bit out of what we have discussed so far because of the need of the institutional integration, and also the epidemiological services that we have. There was a time that we detected more than 10 epidemiological profiles in Rondônia, and now we might have only 8 because at that time we had an intense migration occurring in the state, and in 1988 we had half of the cases of malaria of Brazil, and this had as consequence several projects made nationally to decrease this transmission, and with this malaria has actually decreased. especially because the migration also decreased. So I want to tell you that every outbreak that might happen, it's always related to migration or because of social pressure or economical pressure. So this is a more simple way to talk about things. So we had an initial step for the implementation of malaria elimination in Brazil. And for that, we should have all the parameters so that we could really get into it and believe in it. Because if we don't believe that we can eliminate malaria, if we have people on the team that do not believe it, it doesn't work. So before that, we looked for other alternatives, the best alternatives to integrate the population, the three powers, three institutions of power in Brazil and Rondônia. So we have two plans. So it aims at control and elimination, and there's a second plan that is more strategic, which is about elimination and sustainability, which are two important factors. There are no plans, there is no plan that can work if we don't have sustainability. Remembering that all of the political processes might affect any plan that you can imagine. So we were the best model of vaccination in the world. And in 4 years, we destroyed that. So you can see that there was the need, there was a problem of the state. And so to produce it, to build it, it's hard, but to destroy it it's easy. So with these guidelines, I would like to speak very quickly, and actually a little bit of my time went to talk about those. So there's no conflict of interest, and this is classic. Just to show you. So this happens in the legal Amazon, so until 2024. I'm sorry, I can't see. There is a reasonable amount, and this global increase really occurred. And you can see that until 1989, we had a balance between falciparum and Vivex malaria. So until then, nothing had been done. So there's no action against malaria that is being made in this place. This is an ancient factor, an ancient indicator, but we still use it. So now here in this graph, we have the state of Rondônia included in the illegal Amazon. And here on the low part, we got to a minimum scenario in 2015, 16, and 17. We had the lowest number of cases in the state of Rondônia. So let me talk to you about a parameter. Just to say that here above, there is something called Matopiba. There is Maranhão, Tocantins, Piauí, and Bahia, which is a zone for sustainable development, sustainable projects. And so we had a metastasis towards the Amazon, which is the Amacro, which also uses the same model. So just to remind you, we had the most polluted area in the entire country, which is in Porto Velho. And this actually maintains a very poor environmental pattern. And so malaria per se didn't increase, but the environment was terrible. So having said that, in sequence, I can show you this here the same thing, a macro, which are the areas in which we had invasions and burnings and indigenous reservations and ecological units, and so on. And here we are talking about special areas. Okay? So there's settlement and campsites in Rondônia. It's very complex scenario. Each movement is managed by a coordination that is independent. We all know this as MST, but actually it's not like that. So inside those movements, in Rondônia we had 5 movements. And now we have 4 more. Actually, we have 4 now because we had a fusion between some movements. You can see, the interesting thing is that you can see that inside these movements, you have an organization. Let's say their principles are different from the other. So one movement, sometimes people from one movement go into the territories of another group, another movement, and invades it. So we have irregular settlements in the majority of these movements. So the most complicated would be to face armed people. So just to tell you that this is invasion Três Casas, which is next to Porto Velho. And in this area, we had 170 cases of falciparum malaria cases, and it was solved. And other invasions, and you can see that there are a lot of kids and elderly people that live in those areas. And this is just to show you that it's very difficult to have people in those invasions, because in 2017 we had, for Rondônia to legalize the entire area, we would need 100,000 million reais, sorry, to solve the problem of Rondônia. And now we will talk about mining sites, not in much detail, but just to show you that we have degraded areas in the state of Rondônia, and with very distant houses between one another. And this is just to show you that this is the exploitation site of cassiterite, and we have dry areas and places that have lakes, artificial lakes. And so these are harbors. And so they're like this. And so this site it generates a lot of different mosquitoes and transmission sites. So we had here some machines in the river. So you can see here how it's always a bad situation, because we observed those things, and we had the authorization to get into that. So this causes erosion on the shore of the river, and so they have rugs, kind of. They have rugs. On top of it, we have the minerals that go from one place to another. And so these are other machines. This is the team that we have. We always make the collections on site. And then we have this. This is not to control malaria, okay? But it's something that happened in August this year. We had more than 400 machines, just to show you that it costs, each one of those costs $2 million and 2 million reais, and some cost 12 million reais. So the amount of gold that they withdraw might be extremely high that can compensate for the purchase of this machine. So you can see that most of this gold will never be heard of by us. So this is a richness that is, regardless of what they cause, the environment gets extremely intoxicated by it. This is another thing. I'm sorry to show up in the pictures, but sometimes I couldn't take other pictures, but see, this is a legalized campsite, a mining site. So there's no transmission of malaria here. They have a health unit, so they're well organized here. And there is another class of miners called regueiros, which are the ones that collect the rest of that industrialization and they resell it. Even like that, they are in association. So just to show you that the amount and the kind of people that we have, or patients that we have, are totally different. If we use the same pattern to eliminate malaria in the mining sites, then we would be wrong, because we would be shooting different places, wrong places. So these are indigenous peoples, and in some areas that they live, they get malaria and they move to other places sometimes, and they are semi-nomads. They don't speak Portuguese, and they actually cover an area sometimes of 1,000 kilometers. So the idea is how to eliminate malaria in those indigenous communities. This is a problem for us to solve. And these are stable and delimited indigenous areas. So the indigenous peoples, they cover an area that is delimited. One thing that we discovered is that if we have a fight between some families, they actually just move to other places. And so things keep happening, works keep happening, and it's hard to have control in those areas because the ministry doesn't have any control over it. So then we have a difficult situation, especially in areas for notification. And so you also have dry and wetlands indexes, and so you have to go by car or by boat. And when it rains, we have a difficult time. As we had a dry season, help was sent by helicopter. They couldn't leave the community. So you can see how hard it is for us to monitor that situation. So just to show you that what we think and what we do are very different things, but because this is what happens in practice. So this is just, these are results of health actions, and we had 25 positive cases, and from the total of 117 of tests. And this is just to show you pretty quickly. You can see that what was causing malaria was this light post, because we had water in those little reservoirs, and so the community could see this, and so there was no malaria because they turned this light post the other way around. So it was made. These are interesting situations, and there are other situations I'm not going to explain.
We also have to take a lot of care to have said as urban. So these are not urban areas. These are very distant areas. Usually you take 1 year to get there, and you are in the jungle, and they're considered districts, and it's in an urban area. This is something also to be seen. Quilombolas in Rondônia, we had a mixture back then when they were there. In São Miguel River, they had a very important community there, and also the timber workers, they are the ones who usually destroy the area. Very quickly here, as we set the plan was based in something very important. It's what we call this is the residual, and it's very high, but this was the smaller rate we found. 1,500 cases, 3 consecutive years. We expected to lower a little bit more, and so far it's higher. The plan for elimination must be done exactly in residual periods. Otherwise, you will be working in your plan to control and then eliminate, and this is our problem. And then the plan is about flexibilization. So we use these 3 models. You can see that the assessment is the research for using the usage of people to be integrated and verify how the prevention works in each of these places independently, if illegal mining or not. So it could be illegal mining, irregular, regular mining. So these are situations. Besides that, the gold, casterite, diamond, and other types of ore that could be there, and the emissions are also different. This is a plan we had, and we used many people helped us to shape it. The idea was ready, and we requested all of them to be able to collaborate in the performance. So we had all of these people responsible, and we will work. Here's just to say that in 2018, we had a forum, the release in 2018. I had an item, I'm not sure if you can read, but for all the malarias, I think it's something that we will be able to pursue. We have conditions for that. We had other situations there. This is something more important, I believe, to talk about. In 2018, we had the integration of the actions of the SUS. This would be very interesting, and it would give the plan sustainability, because all the conducts that were used to eliminate the malaria would be done by SUS. Besides some other types of conduction, which is a fund for the elimination And this is fundamental, but it must be something that has the support, the permanent support. So we thought that many states have, and many companies, as power plant, hydroelectrical power plants, and they pay royalties for the usage of a percentage, 1% or 2%, and ad eternum while it lasts. So I believe that this is a political situation to be solved. This is just to say that institutionally, we talked to people when this plan was released, and we had a public hearing because we need support from all the population. The public hearing was done, and we were able to advance. So this is everyone in the public hearing, people who were seeing us, and we had a very important participation, which was the public ministry, which spoke he said that the plan was fundamental, and inside what the public ministry did, he was going to support the executions because many mayors and health secretary were interested in that moment, but once we left, this was not existing anymore. So this was the big problem we had, communication. So the public ministry is an excellent partner in communication. So this is something else we did in the taxation court in the state. They are the ones who do the calculations for the mayors. And when they do this, they basically say what they must do. If the plan is according to what's approved, they have the chance to use the parameters to do as planned. This was in CB. We approved in the committee. We approved. This is important because you legalize the action, and this is necessary for everyone to make the plans. And in here, after that, we went to all the municipalities, and we are still trying to execute. This is just to say that we are going. This is under recovery. Normally, this is it's important for the federal government. I say the federal government because when you have the borders, at least one ministry regarding international relations that should collaborate, the Ministry of the Defense should collaborate, and also the indigenous peoples ministries. So there's a range of ministries that have the obligation to collaborate with us. Not only the health ministry that has to deal with all of this, and it's mandatory, not an idea, for all the cities with the biggest number of cases that they should have their own plan. It makes the lives easier. I always say that without the academy, there's no way for the plans to be sustainable. I'm sorry, I'm over time. I had to rush a little bit. Thank you, Dr. Mauro. Because of the time, we will not open for questions, but feel free. The researchers will be here for all the questions. I appreciate your presence, Dr. Mauro Alexander, and we thank you for such an important speech. And Alexander, by your excellent work that you developed, Dr. Mata and Dr. Mauro are members of Malaria CTA. They have been supporting us. We've been discussing the strategies in special areas. Dr. Mauro is always talking to us, supporting us in politics and using experience. And you, Alexandra, by receiving this challenge for this great work. Thank you so much. We appreciate your participation. Let's take an official picture. Thank you so much. Now, in a sequence, we will begin the climate, environment, and health influences in the transmission dynamics of malaria. We invite the researcher of Evandro Chagas Institute, Mrs. Mônica Carvalho Sucupira, to command the activities. As a moderator, the researcher for the equity of the surveillance, environmental, and health of the worker in the Secretariat of the Ministry, Klaus Kleijman, Sabino Garcia. Good afternoon. Continuing our meetings, we will talk about a very important theme and very recent. We will invite Walter Ramalho, the veterinarian of Pernambuco University, which currently is a professor at UNB, the epidemiology and public health and biology. Thank you. And Coolicize biology of the public University of São Paulo, and Dr. Pablo Amaral, which is a consultant of the Pan American Institution of Health in the prevention program and control of malaria. I'd like to remind all the speakers that you will have 20 minutes each. I really ask you to please obey this time, and after the presentation, we will open for the questions from the audience. Good. Good afternoon. I'm Walter Ramalho. I'd like to say thank you for your invitation. It is a pleasure to be here in Belém. We have the city of Belém as the center, the geodesic center for this discussion regarding the climate change and inequalities. It seems that some people have a laser pointer, and I'm not sure how to use it. And why is it so important? Why is this discussion so important? I think we're getting ready for a point where next year COP30 will happen. I think this is extremely expensive for Brazil. We absolutely have this movement with a lot of strength in the last years, especially from last year to this year regarding this theme. And two themes that are hard for us to gather. I think the public ministry has been doing a very important work regarding this subject. Finally, I'd like that COP30 should bring important and different outcomes. Dr. Florencia, in the morning, she brought a very interesting debate regarding the relationship between the Plasmodium mosquito and life cycle. I actually asked her a question because it's all about my presentation. So the mosquitoes in general, they have a relation with the waters, they have a relationship with the temperature, and the temperature, at least when we work with Aegis, it modulates somehow the mosquito's life cycle, even if it's regarding the diminishing of the cycle. Okay, now I've learned. Even if the modulation of the cycle of the mosquito in their habitat. This is a river creek I got from the internet. I'm not sure if this applies particularly to this one, but we do have some other interference and other relation between the temperature with the mosquito, which is the relationship between the incubation period. And that means the temperature less days or the plasmodium will be developed inside the parasite. And that means we have potentially, when we're thinking about a temperature, it's important when we're thinking about the climate or the pluviometric regime. Well, during this seminar, I saw some very important players regarding the modeling, and I would like to mention that our desire would be for the parameters of malaria in Brazil to be as this author. This author is a South African author, and in the last 20 years, almost 30 years, for epidemiologic week, we had malaria cases appear. In red, the temperature and the broadness of the temperature that was so elevated, and also pluviosity. When we're thinking about the signals regarding the modeling, we want to know if there's any adherence, and if this adherence between the predictory variables, if they influence somehow our response to malaria, which is right here, and it could be somehow predicted by our variables independently. In this case, the author only used the temperature and the rain. I bring here a graph, an equation, a linear system. When we have the linear systems, it does not apply to malaria effectively. Malaria is way more complex than a linear relationship. The linear relationship also prevails a variable or a response to malaria. It's not a Gaussian response. And malaria also cannot be explained hardly only by one independent variable. But I brought here so we can discuss and go deeper in new possibilities. That means when we are trying to predict malaria, somehow the regressive model will be on our table, whether it's linear or non-parametric or multiple. The regime or the model or the regressive model is our tool, at least my way of working. Okay, so if we have here a moment where a certain pathogen is getting to a community, we do not have a memory effect. In this case, we can work with a mathematical model where the X variable is our response variable because that's the human population affected. And other boxes of the compartment model could be taking constant and probabilities, somehow we are able to have the future scenarios when it comes to decision making. It is true that what we wanted and currently much more easily with our ChatGPT area and the machine learning area, which would be to have a data bank in a way that goes into production, and then you have a report, deep report formed, this report having all the indicators and serves the managers um, um, to what they must do for decision making. It is true that this model does not exist. Our friend here, Gabriel's letter, who is the author of this article, has a specific work so that we can have indication and models to create scenarios. It's important to have investment, firstly, in information systems and qualified people.
In this way, we have now a new opportunity, an opportunity related to data science. This professional of data science has some qualifications related to math, informatics, and of course, if he or she knows about epidemiologists, I have no doubt that this person will have a guaranteed work. So I always tell my students, so if today you want an opportunity, try to get deeper into data science. So the new opportunities related to models and algorithms, more sophisticated, even more sophisticated, and sponsored by the investment on computers. It's amazing how in the last 3 to 5 years we have invested on major data centers, especially for machine learning, artificial intelligence. We are we are we are having now power dams that were deactivated just to provide more power to these new studies. So using satellite imaging, meteorological sensors, working with solar energy, we can put it everywhere in the anywhere in the Amazon. We have surveillance and monitoring of diseases. Today, with the discussion about the construction of new information systems, and I'd like to make clear that we have to work more with genome, with genome surveillance and entomological. I guess we have lost a bit of speed on those aspects because of COVID, especially. So even if we are thinking about the signs and those modelings need a past life that is organized, we still have some happenings in the world that make us surprised. This is what happened in Spain last year. We have to talk about this. In the center of the Amazon, there's something that is being felt, and we don't have a prognosis that is more accurate, but we believe that we know that something is happening. So we have been discussing also what is more valued. So here we have a measure among in economics and environment, and this is a good discussion about what is going to happen at COP. So I would like to make clear that we have a climate exclusion of people, and is our world changing? Is it really changing? So we have our colleague that gained the Nobel Prize, and he's talking about equalities and inequalities. So this is a polemic image as well. And I'd like to talk about my satisfaction of having a new organization in the Ministry of Health. There's the new general coordination that talks about climate change and equity. This is an old topic in health, and it's important to say that when we are talking about inequalities, we are saying that the health events do not happen equally and in different human groups, but we have some underlying causes. We are using the terms determinants and conditionants, and there's the here's the John Snow map to tell you that the epidemiology is very close to health, and when we have systematic differences that could be avoided by acceptable means, and health services could assist in an equal way and considered in just from a worth point of view. So this is this picture is a symbol of what we have in Latin America. So this is a map, a representation of what a study that was made some time ago, 1995. This came from a master's degree from a person that could be the chief, could be the boss of some people here in this room. So with through homogeneous aggregated, he created Nelson Moraes curve. This data is not well used. So through economical layers, he concluded the probable mortality, and with these curves, we can see the differences in the patterns of life expectancy in the peoples of those communities. So today, this person that continues to be our boss continues to talk about this topic that we need to have social, economical, and political conditions that is more equal. And you can see that I'm not talking about equality anymore. I'm talking about equity. So inequality is a measurable dimension, and inequity studies in health, and this approach demands differences, variables, and this predictors might be a stratification by gender, income, etc. So what we might need to do is a judge of causal relations that is very important. So here we have a funnel showing that the emission of CO2 in the world is made by 50% of the richest people. On the other hand, it appears that the world population suffers the consequences of CO2 emissions and climate change. We're not alone when we need to get deep into the topics about inequalities. So here we have a chapter here only about social inequalities in health. We have different public, and we have an important monitor, which is the Health Inequality Monitor, and it was organized by WHO, and it's organized here with not very updated, very much updated data. So this is malaria in Brazil in the year 2000. In the year 2000, in this graph, here we have a distribution represented by the states, and the indicators are the deaths by malaria in kids under the age of 5. So we had an amplification, a great difference between the states. So this last year, 2019, we had a reduction of these differences, of these disparities. Once again, I'm talking about disparity, not inequity. We don't have a socioeconomical variable. Here we have the incidence rate. It is 20 times higher in Acre compared to Pará. So the indicators that are normally used are typically of epidemiology. So with this rate, we can first have data with simple stratifications. We can have groups of cities that this is the case of a lower child death, and with that percentile that is higher. So we have the difference between the rates. In other words, the group of cities that have higher risk for child death is higher than the other groups. So it's very easy to understand. Sometimes we are dealing with data that we can measure. If we had an equal situation, how many deaths we could prevent? So in this case, this year, 3,308. So when we are dealing with inequality measures, we can see here, we have a possibility to calculate the Lorentz curve. Once again, Lorentz curve is an accumulated curve that measures. Please put it again, put the presentation again, please. Lorentz curve measures a concentration in the mode of differences and how much different we have, how much difference we have from the equality curve. So Lorentz curve shows graphically this difference, and through the gender indicator we can see, actually the indicator is the one that we have imported from econometrics. So in this case we are talking about inequity. Before we had differences, inequalities, and here we stratified with the GDP, and we are seeing here the experimentation of cities according to its GDP. So if all cities had the same GDP experience, we could see that the child mortality is extremely sensitive to poverty. So we could have a reduction in the cases of deaths. Even like that, we have an index of concentration, so you can see that the concentration changes, so it's not the Lorentz curve anymore. If we are stratifying a social economical data, now we are using curve of concentration. Even like that, we have a concentration index that is reasonable, 0.036. So we have a note study that showed how the concentration of malaria in the Amazon region. So malaria is something that is extremely concentrated. We can see that 90% of all the malaria cases was concentrated on 20% of the population of the Amazon. In other words, the higher the concentration, it is more plausible, the more we can think about its elimination. So this is a representation by cities, and we can work in each location. We were discussing the necessity to have cities as important units of analysis. Why can't we do that? And we can bring together those two works related to inequalities and climate change on a place that life is reproduced and the ecosystem is reproduced, the ecosystem that produces malaria. I would like to say that even if we're conscious about the existence of inequalities in Brazil, we're living in a period of climate change. And so I reinforce that the studies should be promoted, because the more we can show from the point of view of policy and advocacy, we have to reinforce that public policies need to be dealt with. They need to happen. And I'd like to say that nothing is guaranteed in the future unless our effort and consciousness, except for our consciousness. I'd like to say that there's no conflict of interest here. And thank you for letting me pass this message on. Thank you, Professor. I'd like to ask Dr. Marianice to speak, please. Well, initially, I'd like to say good afternoon to everyone. And I'd also like to thank the organizing committee of this event for the invitation and for the honor to be participating of it. So I'm going to talk about the impacts of climate change and use of land. And the occurrence of mosquitoes, malaria mosquitoes. So we have these two maps, one of 1983 and the other one of 2023. And this yellow part is the degraded area. So we can see areas that are less degraded and areas that are more degraded. And we have different points distributed in the on the map, and these areas are being deforested. And it's an interesting data. Between 1980 and 2000, over 80% of new agricultural land represent a devastation of tropical lands. That's in the world, and with an estimated annual forest loss, tropical forest, of 2,100 square kilometers from 2000 to 2012. So what does this have to do with malaria? So we have to understand that malaria is an ecological system. So the transmission of the plasmodium and the occurrence of malaria depends on numerous factors. And among those, we have the biotics factors. So factors in the biological environment abiological factors in ecology and the factors associated to human ecology. And just to cite some examples, in the abiotic factors, we have to think about temperature, precipitation, not only that, but in hydrology, and also the use of the land, changes in the use of land and forest cover, among other factors. And regarding the biotic factors, we have to think about the plasmodium species that are circulating in that environment, and also the duonophilous species, which are the vectors that transmit that plasmodium, and the human host, and also the biodiversity present in that environment. About human ecology, we have to think about the demographics of the population, the social structure, economic structure, and the health structure. What are the services available to the population in the migration patterns, and also human behavior that expose humans to mosquito bites. So in the case of the vector, the longevity of the population, the feeding behavior, and density and abundance.
These factors I've mentioned, these four groups of factors together, they determine both the vectorial capacity of that population and the transmission standards in space and time of the malaria. These relations, they become more complex when they occur when there are alterations in the natural environments. For example, the deforestation for agricultural expansion, diverse changes in the use of land, urbanization, and many other factors that need in environmental change, especially in the tropical forests. This is a work that I will present as an example. This was developed by Chagas and collaborators in 2018, and the authors showed that 1 square kilometer of deforestation is correlated. In that moment, they used the data bank in the health ministry from 2019 to 20. And then 1 square kilometers were related to 27 new cases of malaria. This was an elevated correlation and statistically significant. And they also showed that the fragments with a smaller area than 5 square kilometers, they were highly correlated with the incidence of malaria. And these small fragments corresponded to 95% of the fragments in the deforested areas that were observed in that area of study. So the authors come to the conclusion that deforestation contributes for the favorable conditions for malaria transmission and also the intensification of that transmission, and that depends on the socio-ecological conditions and also the economical conditions in that environment. So this deforestation is associated with environmental and economic conditions. Well, a more recent article published in 2024 by Arisco and collaborators, somehow using a bigger data bank and a different dimension, and also performing analysis in these different authors, come to the conclusion that deforestation is related to the biggest occurrence of malaria. And they showed that a raise of 1% of deforestation in a period with a delay of 1 month represents a raise in the occurrence of malaria in that municipality where the deforestation is happening, of 6.3% of malaria in that municipality in a certain month. And that means this is a very important raise of the occurrence of malaria. This is not in the Amazonian region, this is in the Atlantic forest, but the climate can also somehow provoke the change of transmission in malaria, and it occurs. For example, I have Anopheles dainese, which is the dominant vector in the Atlantic forest in Brazil. And regarding the rise in temperatures, but there's a diminution on the incubation time in the vectors, both for Plasmodium vivax and falciparus. We also have a rise in the survival of the female Anopheles dalange, and this leads to a rise in the risk of malaria in the areas where these mosquitoes are present, and also the possibility to expand with a rise of temperature for regions southern to the Atlantic forest. They use two climatic models, RC 8.5 and 2.6, and they use the climatic model of climate change. Now, going back to Darlene, the relationship between deforestation and the malaria, and also the collaborators to understand the percentage of the forestal coverage and the density of the forest borders, which is the approach for the fragmentation of the forest, and how it relates to the diversity of the mosquito community, and also with Darlene. They tested the hypothesis of association between the structure of the landscape and also the dominance of Anopheles dalange. So this is a summary. The authors observed that the dominance of Darlene is associated to the diversity of the community of mosquitoes and the border density and the fragmentation of the forest, and also the fragmentation in the forest density. They noticed that the raise in the forest coverage of one unit only leads to diminishing of 533 individuals of Anopheles dalange, and the diminishing of the Shanu index that we use to calculate the diversity of communities. So the raise in one unit leads to the diminishing of 226 individuals of Anopheles dalange. And that means Anopheles dalange is negatively affected by the raise of biological diversity, also the range of the forest coverage. And our general conclusion is that the tropic alterations in the Amazonian vegetation leads to dominance of Anopheles dalange in paradomestic environments, because the focus of the work was what happened in this type of environment. This is another work also by Chagas and collaborators, and they were interested in verifying the peak of female activities, infected females and non-infected females in many gradients of forest coverage. So they defined three tracts of global coverage. So they found the infected females and non-infected females in these places. They were all areas for rural settlings with parasitary index above 30, equal or above 30. And the authors observed that the biggest number of female individuals that were not infected, they were collected in environments that were more deforested, and that means the percentage of forest coverage equal or under 30%. And this peak occurred from the 6 to the midnight. In a different way, in landscapes with a certain degree of degradation, this degree varies from 30 to 60% of coverage. So the activity of the females who were infected by Plasmodium vivax. So the peak of activity of these females occurred between um, 9 and 11 p.m., but in vegetal coverage of 30 to 60%. In the falciparum cases, the females that were infected with falciparous plasmodium, they had biggest activity in landscapes with 30 to 70% of forest coverage, and the peak of activities occurred between 10 and 11 p.m. This other research is not it doesn't regard to Brazil, but it's very important. I think it would be interesting for us to verify what happens in Brazil related to hydrology, also related to the susceptibility of the hydrological standards. And they observed in Africa both the diverse climate change models and also hydrological models to verify the adequacy of areas for the occurrence of mosquitoes habitats and malaria. In this case, in Africa, we had Gambus and Malarias and other species. And what could happen from then, and what happens regarding this hydrological standards. So in conclusion, super summarized, is that the hydrological models allow us to have a better prediction of the areas of occurrence of malaria, the areas with biggest adequability for the occurrence of habitat of mosquitoes and also malaria. And it also offers the more accurate prediction than only the climatic models. And the adequability of the malarian areas could diminish, especially in areas from the west of the African continent, but in regions of the river corridors and the plain regions along the corridors could occur an augmentation of the adequate areas for the vector of malaria. They also discuss that the Nile River in Egypt, currently an area with no malaria occurrence, could become highly adequate to the occurrence of malaria. And also other areas from the higher regions of Ethiopia, which are not adequate to malaria also because of the temperature, that with the climate change and the changes in the standards of precipitation, they could become adequate for malaria occurrence due to some processes that are adequate for the vector mosquitoes and of the dispersion of these mosquitoes in areas where they do not occur due to colder temperatures. This other work was done here in the Amazonian region with Arisco and collaborators in 2024, and the authors studied in models analysis of network, cluster analysis, space cluster analysis, and also linear models. They examined the movements of the malaria cases in the Amazonian region from 2004 to 2022. They observed that the movement of cases between states is gaining significance that is super relevant regarding the dispersion of the infection by Plasmodium in the Amazonian landscapes. And they defined areas of production of cases and areas that receive cases, and the behavior of malaria in these areas is different. So, for example, in the areas where the movement of cases, in areas that receive the cases, they have a more seasonal aspect, and in the areas which produce the cases, they depend, it's not seasonal. And this is a question for you. Is it possible to eliminate the malaria without an environmental approach and without the reduction of poverty, and also without collaboration, cooperation that should be multisectoral? This is for everyone to think. This is a food for thought. Thank you so much. Thank you, Professor. Now we invite Dr. Pablo Amaral for his speech. Thank you. Thank you all. Thank you everyone present. The advantage of presenting a little after Adelis Duval is that a lot of things from my presentation were already mentioned. So we've gained some time in the presentation. Well, firstly, I'd like to thank the organizers for the invitation to be able to show a little bit of the work we do in the coordination of the administration of malaria with the program and the plans for the environmental and when in the implementation of big endeavors in the Amazon. I like these maps for us to remember how much malaria was distributed all over Brazil. So we were discussing this this week with Gilberto Morisco. For us to talk about the elimination plan of malaria in Brazil, we usually say that it didn't work. It really did work. We had malaria all over Brazil except for the south. And now malaria focused in the most natural environment in the Amazonian region. And in this specific case, I really like this image for us to understand that all over Brazil, we have the vector, we have Anopheles. I am from Brasilia. A while ago, we were having a capacitation, and this colleague, Gilberto, had collections in Brasilia in a park, a very urban park in Brasilia, and collected Anopheles in a park in Asa Norte. I can't remember the name now. And malaria, as we talked before, it has this big role in the environmental inequities. So it is a broad and distributed disease in more than 57 countries in the world, and it's a big cause and relates to the social inequalities. So what factors are associated to the malaria besides the vector? As Maria Eunice has just presented, we have this tripod, an epidemiological tripod, and it's a very important factor in this occurrence in the environmental changes. That climate change have this very important role in the malaria occurrence in Brazil and all over the world. So environmental factors as deforestation, illegal mining, expensive agriculture, as Mr. Mauro Tada showed. These are factors that take both the occurrence of malaria by the new environments for the vector, but also the presence of human beings and people in the areas where in the past you did not have any occurrence. Recently, in 2022, if I'm not mistaken, we had a publication by Science that showed how much these environmental advancements have been provoked by the anthropic action, accelerated by anthropic action. As I mentioned, social demographical actors, so housing in inadequate areas, the fish tanks, which are a source of food for many communities, but if we do not care on how it's going to be built, it's also a factor for the vector proliferation. Types of housing, as Marta showed before, these adaptations in mining areas, which are done without any walls and without any protection. And there's political and economical factors that in Belém, we have this reflex of a past where we had an expansion of the colonization. People in a certain community, in an indigenous leadership corrected me when you say not colonization, but the invasion, the presence of white men in the Amazonian region. This was already occupied. But this advancement happened with the rubber cycle Belém had this expansion, this occupation that was super expressive, and also the occupation of the Amazon and the dictatorship in the 70s, where we have integrate not to deliver. Amazonia is gone, no more let's occupy. And this occupation, this advancement is related to when you talk about the environmental licensing, these big companies, many of them were broadly impacted by malaria. And this is an example. One of the biggest example is Madeira Mamoré from Porto Velho. And rumor says that for each person sleeping in Madeira Mamoré, there was a dead body by malaria. So this was a disease that stopped the these big companies in Marcha Rondon to be happening, and they had big working sites with a big number of workers, and they had this care. Chagas is there in the region to try to control and understand what was happening. And then you had the researchers using these outfits due to the huge number of vectors in that place. And that occurs to this day. This occupation of the Amazon has caused social impacts that are significant, as we have had the recent case in the Yanomami caused by the illegal mining. And besides all this, since the Constitution of the 1988 as health being one of the environmental impacts in CONAMA 01 that talks about environmental licensing, malaria is the one disease that has a clear and well-defined process in the environmental licensing. Currently, by the 21st law from 2014 and 2015 brings all the how it's supposed to be done in risk areas. Is the municipalities where the ministry has a list. If you have at least one case outside the Amazonian region in the last 3 years, they must have a specific plan for controlling malaria. And the big companies that we see in the Ministry of Health is about the generation of energy, mining companies, roads, ports. Since 2008, the Health Ministry has been following the licensing process, and in the year of 2023, we reached the peak of almost 44 new endeavors. And then I like to keep this linear graph, and the number of companies that we follow, they do never leave the radar. Just as an example, last year we have had a judge requesting information about the Telespires power plant, and it's over. This doesn't happen anymore, and we are still following this process. So we had this total group of process that almost gets to 200 processes followed by the Ministry of Health. Big part of them is transmission lines. This is the biggest typology that we have in ministry. Also roads, so linear buildings. They have their advantage in the sense of impact. They are faster. When it comes to people, we also have the power plants, the hydroelectrical power plants, which are located in one place where you have a big number of people working and populations that come for company and indirect work. When you have a hydroelectric plant, they will have hotels and also other health problems with have a lot of prostitutes, and we also have the raise in the STDs. And we have other endeavors that we follow with the health ministry. In yellow, we have the thermoelectrical. In green, we have the linear ones, which are the roads, transmission lines, and they're focused on the Amazonian region, but also we have also the outside of the Amazon, anything that crosses the line, which I mentioned, at least one case in the last 3 years.
So this image is here just for us to understand the number of enterprises, the amplification, and their distribution in Brazil. So just so we understand the size of it, this image was taken on the construction sites, and for the time and memory, I can't remember it quite well. I guess it was Jirau or Santo Antonio. These are the two power plants that are inside Porto Velho. So these were the number of meals served in all four canteens that we had in the construction sites. So for 3,000 meals per day. So we had two canteens, 3,000 meals served, and inside the power dam, we had practically a bus hub. So it was practically a city. Just so we have an idea of the number of people that are brought to the enterprise of a power dam, which is one of the main examples that we have. So this study, this worry, this concern with the new enterprises is something that already happens, especially for the states. So again, we have this with the new PAHO, which is the promotion of development. So we will have an amount of money for the constructions, and the PAHO only for the Amazon region, we will have 448,000 million reais. So we have great enterprises, and of course we have here smaller constructions such as schools, but also roads and power lines. Great enterprises that will happen, and with this we will have more enterprises in the region. And I have only 8 minutes. So what are the main impacts that these enterprises cause, and how we can think, how can we think for them to happen with following regulations? So these are the illegal minings and the industries, which are the legal miners. So in 4 years, before the beginning of the construction and after the beginning of the construction, we can see that in the mining sites you have a boom of cases, more than 100% of increase in the beginning of these 4 years. So when this mining begins, the migration of people that go into these sites, the number of malaria cases increases, and then we have a decrease, maybe because with time it is harder to extract gold. And the Secretary of Health of the state has knowledge of that side already, so they can have more actions happening in the place. And in the legal miners mining sites, so in a area that was covered by IBAMA, since the beginning of the construction, there is a decrease of the number of cases, because we have the employees using long sleeve shirts, so they will work from 8 to 6 p.m., 8 a.m. to 6 p.m. And so this person leaves the field, the working site, like 4 in the afternoon, and there is another study that we have been developing, which is the impact of great enterprises. And this is the index of malaria cases. And this is Santo Antônio and Geral dams. And so I had a joint point graph. And so there's the number of cases before the installation regulation, before the installation permission. So they have to follow some regulations by the Ministry of Health. And there's the period of licensing and when they can start to operate. So I powered them. This is the graph of the beginning of the operation until the end of the operation. So afterwards we have less employees as well. So there is Belo-Monte, the Belo-Monte case here. So here is a set of data of Altamira and other cities on the surroundings, such as Anapu, Vitória do Xingu, and it's compared with the state of Pará. So just during the period of construction of Belo-Monte, the number of cases decreased. So the same thing for Santo Antônio and Geral, which are power dams that are in Porto Velho, and they were built together. And the license for operation is it occurs close in time. And another example of this analysis is when we have a micro-analysis, when we do analysis in the places where the dams really are. So you have a decrease and during the period of construction. So on the top we have Geral, Santo Antônio and Geral. And on the bottom you have a decrease in Santo Antônio right after the construction, but significantly you had a decrease in the number of cases. And during the construction, you have here a decrease of cases. So showing that we have a positive relation between the actions for controlling malaria and the number of cases. So having a licensing, on the contrary of illegal mining, the licensing is a protective factor. So when we take a look at the micro location, it's important because the cities of the Amazon region are the size, almost the size of countries. For example, Porto Velho. People joke with me because the complete name of the city is that Porto Velho is bigger than Belgium. Altamira is actually very big, the third biggest city in the world. So also Jacareacanga, it's also a city that is giant, where you have mining, indigenous sites, indigenous units. And just as an example, when I went to a place there to do a monitoring, and we asked the secretary to go there. So Jacareacanga is right here on the map. So the secretary said she couldn't go to the meeting because to go to the neighbor city, she has to travel from Jacareacanga to Belém, São Paulo, Brasília, and Paranaíba. So to get to the neighbor city, there's no road there, so she has to travel all this way by plane to get there. So how is the population going to get, how is the public health going to get there? And also talking about this topic, the deforestation in those big enterprises has a direct relation with the malaria cases, and with this alteration that the enterprises, legal or illegal, are going to cause, and they form new larvae habitats, there is a greater incidence of malaria in those environments. There's some data from 2018. Every square kilometer causes 27 cases of malaria. So when we take a look at the consequences of these enterprises, we can also see that there's the displacement of the populations. For example, this is an important example of Mariana Dam. So the people from Mariana, where we had a destruction, people had to be moved to other places. Then this movement of people increased the transmission of malaria. So last year we had cases in the United States, in Texas and Florida, and one of the explanations for it is this great international transit that the United States have, and also the rise of temperatures that increased the occurrence of the vectors. So this location, this movement is going to cause reintroduction of cases, impact on health resources, and to have the example of Belo Monte, Altamira, for example. The city was still in the beginning. It was very small, so a great number of people moved there looking for jobs. So this has created a severe impact on the health structure and education and so on. So I would like to thank you. This is our team for the elimination of malaria in the health ministry. We are short on three people here. And I would like also to thank the lab of medical parasitology and vectors biology, where I am having my PhD. Thank you very much. Good afternoon, everyone. Thank you, Pablo, Professor Nisi, and Walter. I would like to congratulate the organizing committee because I am particularly thrilled when we can participate of a roundtable where everything was systematically well thought, and we can see a reasoning line. So, for example, Professor Walter talked about inequity and crime and health, and we can see that the people that suffer the most are the people that contribute to it the least. So the most remote the place, the more severe the impact. So recently we have had occurrences of burnings happening in a large scale, and it had an impact on indigenous communities that had to move because of the proximity with the fires. And so we correlated with the deforestation, which contributes a lot to the increase of vectors and temperatures. So with all of the scenario, I guess it's important to rescue it a little bit. So I have a question, especially for Dr. Nisi, and the studies that you have presented were of the year 2020, and in 2023, and now we had a rise in temperature that happened before we thought. So the number of heat waves in Brazil has increased, and we could see the reintroduction of dengue in areas where we didn't have dengue. So how worried should we be in Latin America with the reintroduction of malaria in areas that are close to eliminated 100%, or the number of cases in Brazil on the short and long term? So is it working? I am not sure. I guess it's not only the climate change that are responsible for the increase in the number of cases, not malaria, not in dengue, because the mosquito responds to the environment. So if you have an adequate environmental scenario that offers good ecological conditions, then it will proliferate. So we create an environment that is suitable for the mosquito. It's not sometimes suitable for man, but the mosquitoes know how to adapt to these new conditions and proliferate, especially vectors of pathogens. These are the ones that become most abundant in the scenario of environmental change and climate change as well. And this might have some relation with dengue. But there is the rise of temperature, but in urban areas, the problem is that they maintain temperatures in urban areas that varies little during the day and during the night. So you have small fluctuations of temperature in the urban areas, and this favors the development of Aedes aegypti and the development of virus in a vector. So you have that way a higher transmission rate. So what else have you asked? Did I forget to discuss anything? Yeah, the possible reintroduction. Yeah, so in this work of Anopheles cruzi, the work was thought in the macro-Atlantic area. And so we used different models, climate models, to understand the survival rate of the Plasmodium in the vectors and the period of incubation, which also had a positive variation for the Plasmodium, and also different scenarios of environmental change that predict the rise of temperature. And with this, they could verify that it is possible for malaria to extend to regions where it normally doesn't occur nowadays. So we could have, yes, the intensification of transmissions. Yes, we will open now at least for 2 questions, if the participants are here. If the participants have any questions. So I'd like to congratulate the speakers. I don't know if you can answer. Anicia, for example, the deforestation topic, which is highly correlated with malaria. And it's very much complex. So it comes from this, small deforestation until this industrial kind of deforestation. So what is the deforestation that we are dealing with? Is there a difference of risks? And are there advances in those areas? So let's finish with that question, please. Yes, thank you for the participants. My question is for Dr. Anicia. My question is about humidity, and on the other hand, about herbariums. We have hydrodynamics, and we know that the temperature causes, sorry, didn't get that. Hello. I've learned that I cannot hit the microphone because the translating team suffers. So answering that question about kinds of deforestation, there is a big difference. So when we talk about environmental licensing, we are talking about the impact on these greater areas and
in these small ones, there's also a risk. I'm actually going to change when you talk about the fish tanks, the importance of having education and health for the agriculture and the fish, where you have the control of the grass around the tanks to avoid the proliferation. So we've seen this in the work, especially in the municipal supporters that are there for that type of work. We have this work for tanks that are not being used for education and health, where we will manage the smaller areas. So the tanks and the extraction, the vegetal extraction, is an impact completely different from what we're saying for a big endeavor. So this is a difference. You treat the multiplicity, the different things in a different way, and the equal thing in an equal way. So of course, you would treat about the more artisanal with the education and health. For the final partners, you have INCRA, Embrapa, Emater. These partners in the control actions is fundamental for the reduction. Now, just adding to what he said, there's a big difference between the standard of deforestation and regarding the malaria cases, and that means the equability of this environment for malaria. In general, when you have deforestation of a small area as a stain in the beginning of the deforestation, in these moments is where you have the malaria. That person is isolated in some areas, so they're starting the deforestation. The conditions are not adequate. But when you think about big endeavors that tear the forest down, you cannot even think about malaria. In these areas that are being deforested little by little, you have the reduction of trees, many types of trees, commercial and non-commercial, and this changes the forest little by little. This also fragments the forest. So you raise what we call in ecology the border density, which is equivalent to the fragmentation for the forest. And in the case of Anopheles, it responds well to environments that are being initially deforested, and their habitat is in the borders of the forest, and with the deforestation, some of the environments that were lotics, they become lentics, and it changes the distribution of water in that environment, favoring the habitats for the Anopheles darlinge. and that means they become abundant and dominant in these environments. After being open, we have other types of mosquitoes, other species that can dominate that environment. And some of them can be the malaria vectors, but more local, not dominant as the Anopheles darlinge. Now, answering about the hydrological cycle, when you talk about hydrology, you're thinking about the distribution flows of water in the environment. So how can the water flow in that environment and where it accumulates? And this is associated with the larvae. It's not only the precipitation, obviously, it's important because we must have water, but it's not the precipitation itself. It does not determine that this water will be in this environment and become a habitat for the mosquito. This is why the authors they talk about the hydrological flows and the hydrological models for understanding better what will happen in African areas regarding the adaptability to the mosquitoes and to the malaria vectors, and also thinking about the climate models. So I think it's interesting here. I didn't recognize any article talking about hydrological models and habitats for Anopheles darlinge or other species of vectors, but it would be very interesting for us to observe what happens with this draw that happened. Obviously, the water is over. It was redistributed. This is regarding the mosquitoes. I'm not sure what happened. I would like to add here regarding the new possibilities, new sensors, and today we have a bigger spatial sensitivity, and it opens a possibility for studies that are much more sensitive and more localized. So I think this possibility is given today. Well, I'd like to thank in name of the commissions to the speakers. This was a pleasure to receive you, as always, with excellent speeches, and this session is closed. Thank you. We appreciate you, ladies and gentlemen. Thank you so much. We will take an official picture. Now we will have a 20-minute break for coffee break. When everything else fails, we have to talk about drugs and anti-malarian medications. And she works in the development of drugs and the discovery of new innovative actions for medications, synthetic medications or natural medications. And we will have this moment for getting to know this other side, which is so important, which is the installation of the resistance we need for a good response for the elimination. We must attack in many fronts. So please, Professor Celia. Thank you, Professor Eduardo, for this introduction. I'd like to say good afternoon to everyone. I'd like to say that it's a great satisfaction to be here in the malaria meeting in Belém, in this beautiful city, to see so many great friends I have, and to have the opportunity to learn more with this program. Well, I will, as I said to you, to show the work we've been developing in the University of São Paulo in the Pharmaceutical Sciences department, and it's related to the aspects in the molecular and parasite with the identification and manipulation of new targets. I certainly do not need to show, wow, this is a very big ball. I don't need to show for this audience the parasite cycle of the malaria, but the intention here is to call your attention for a work that we have been developing, but many labs around the world, even though the parasite develops inside another cell in case of the sexual stage is the hemesis, it's got this great capacity to understand the microenvironment and use this microenvironment and the signaling of the microenvironment to regulate the aspects of their cell cycle, cellular cycle. So this is what we base our work in the last years. I'm not going to go into details, but we have work that show that molecules derived from the tryptophan with melatonin and are able to modulate the parasite cycle nergic receptors. So we have studied this a lot as modulators for this cycle of parasite and so on. Now, how can these molecules and what is the role of these molecules in the cycle, the parasite cycle? This is our challenge to try to understand. I also don't need to bring to you this urgency of the need to identify new medication due to the resistance to the classical medications. This is just a map so we can re-see this memory. So the lab in these years, we have three main, I would say, interests. We have a very big interest in medicinal chemistry. So we have a considerable part of drug screening. So if you're a chemist or if you have any type of library, we can talk. And we also have, as I mentioned, the interest in identifying, the interest to identify as I said to you, to study the aspects regarding the cellular cycle of the parasite and how it interacts with the environment, with the goal of identifying new targets, and also something very recent that we've been doing in the lab, which is a methodology based on a methodology that is used for the development in the industry, which is based in the membrane receptors. So I am going to show you some of the breadth studies and from the identification of these receptors, these membrane receptors in the plasmodium, the falciparum plasmodium. As I said, the lab has this interest to working on on seeking anti-malarias, and we are associated with many other labs, which are chemists and synthetic, and the guys who work with the natural products chemistry, and we have a very big association with them. It's a work that it lasts a decade now. And this is just a sample of a few of the works we've been publishing in the medicinal chemistry area, which really is super interesting. It's an area that gets our attention a lot, the attention of our lab. Now, going back to the biology aspect of the parasite and its alteration, the host alteration, one thing we've identified a few years ago was that the parasite is able to be synchronized. It loses synchrony when we put it into culture, and it synchronizes back when we add compost regarding to indole. They have their structure, indole structure, and one of them is the host hormone melatonin. And one of the identifications that we have of signaling of this parasite was the identification of this protein, which is present in many other parasites. It's a protein that is very important for the epigenetic regulation. So we've identified, and we put this gene into a GFP, and we can identify that in green. And you can see that along all the whole cycle, it's in the nucleus. And the knockdown of these protein showed that the parasites, they lose their ability to be synchronized with melatonin. So at the end, the synchronization reaches in the nucleus somehow. So we have had this collaborative work with Isandel and José Lima and Jepo Pausano from USP, and we've tried to identify who were and which were the molecular partners of this MORC. And we found transcription factors, among them a gene that you have heard a lot, which is important for the differentiation of the parasite, which is the epithel gene. And this is a recent work that was very interesting in this biology line, cellular biology. And one thing that is really the heart of our lab and that we are super interested about is the signaling by calcium. Why are we interested in calcium? Calcium is an ion messenger, is a signaler, and is universal. So in a process like this, if you think about many processes, they occur very quickly in mammal cells, in synapses, or apoptosis, and motility, and cellular proliferation. And now that's for mammals. Even to get to the muscular contraction, which is or fertilization, which is a process that takes hours, they're all based in calcium signaling. And how can the parasite deal with this signaling, calcium signaling issue? So this is a subject that we are super interested for years, and currently they have their role well recognized, and in many labs, the calcium participation in the outcome in the parasite coming out of the cell and the invasion, and which are fundamental points for the parasite biology. And these are processes that depend on calcium. Also, utility and the activation of the gametocyte. So these are things that have been studied a lot worldwide. So the first question that we asked ourselves and published a while ago, okay, the parasite can use calcium, but how? How does it do it? If you compare the means that they survive, is very different from other cells because they live inside other cells. So for example, regarding calcium, the concentration of the extracellular means is about 10 times smaller than it's supposed to be in the extracellular means.
So this is a work that has been developed for some years by a PhD student, which is a professor at, who is a professor at UNIFESP. So he used two different biomarkers, and with this marker, as it's sensitive to calcium, it can measure the amount of calcium inside the cell in between the membrane of the parasite and the membrane of the other parasite. So what was the objective of it? So the hypothesis is that when the parasite comes into the cell, it's formed by another membrane, and in that region, this region would be high in calcium, and it would compensate. It would compensate for the fact that he is in a hostile environment, which is the inside of the cell. So it means that it could survive using calcium. But if we pay attention to this part now, on your right, how? So here he deposits calcium, and it's interesting how all of this road map happened. So taking into consideration how these signals occur. So how these plasmodiums can be generated in this process. So one of the first works that we published. So one of the first interests was from Robert Alvine, and he worked with receptor of P3. So Robert in England, he synthesized this P3. So we used part of this P3. So we broke the cell of the parasite to study these calcium deposits. And so in P3, we could see a rise in the middle of the cell. And at the time, we added chloroquine because as this deposit, this digestive compartment, the acid compartment is a place where we have an ionic value that is prominent. So we could see that chloroquine was able to liberate calcium in those parasites. So it happened years ago. And in a recent collaboration with this other lab, using many different genetic loci, we can see the existence of this second acid compartment that is liberated when we add Viana and chloroquine, showing that beyond the endoplasmatic, this was shown in Trypanosoma cruzi, and it was imported by Roberto do Campo's lab in the United States. So if it deposits, if it has calcium inside the reticulus, then it won't have any more calcium to signal. So how do the cells deal with it? So there is normally a communication among these compartments that have deposits of calcium and the intracellular mean. So immediately there is a filling of these deposits. So what we had in these works is that the parasite demonstrated this mechanism, which is sucky. So we have calcium in when it's depleted. So more recently, our laboratory constructed one of the first transgenic parasites to measure calcium, and these parasites are expressing a GFP, which is fusioned to a portion of commodulin, which translates the signal of calcium inside any cell. The parasites also have this, so you can see these brilliant parasites here above. They are expressing this GFP, which is GCAMP, and it can be a sensor for calcium. As you can see, the CPA increases calcium, and more recently, with Thomas Laboratory, we demonstrated using GCAMP that the parasite really possesses this calcium. So everything is okay, it survives, it has a signal, it has calcium, and it demonstrates that it can refill these deposits. So how does that move? So normally the cells have a system, phospholipase, P3, and in this work we have G7. So there is a hormone molecule, and it only liberates calcium in the presence and in the absence of extracellular calcium. So it means that there really is a deposit of calcium that is mobilized with the contact of the parasite with an environment that signals this liberation of calcium. And what we did afterwards was to demonstrate that the parasite can liberate calcium from P3, but not making the cell permeable. So indicating with a fluorescent indicator and having a molecule that can enter these membranes, it can cross these membranes, and once it suffers a flash of light, it is transformed into a IP3, and then it liberates calcium inside this parasite, which is what we can see here in this first graph in red, and the control saying that if we miss caged IP3, the flash of light does not liberate any increase in calcium. However, these cells are perfect as the liberation of calcium as is shown here. And we have, so the flashlight cannot add any more calcium as this graph shows down here. So this work had other developments trying to block the cycle of liberation of P3 with derivatives of APB and the IPB itself, which is a liberator of CO3, and it blocks this liberation of calcium and the development of the parasite inside the blood cell. So all of these works, not only from our lab, but works from other laboratories, point out to the existence of this connection between IP3 and MDR. So there is no, it makes us think that the parasite has elaborated another strategy to mobilize calcium from these reservoirs with a channel of calcium that is not the classical one. So Eduardo Alves combined the chromatography with affinity to IP3, so it has extractive parasite in this column, and he compared with a column that didn't have it. So he isolated some candidates, and when they didn't have any functions, They were not indispensable because we knew that this receptor, IP3, was possibly important, and also candidates that didn't have the transmembrane. So the candidates that presented a docking potential for IP3 with a modeling of IDR were then selected. So with this, we believe that this MDR, which is located in the membrane, the digestive spot, is from the parasite. So this work was made with Eldo Nakaya, and he did this interaction of MDR. So what calls our attention is one of the proteins that MDR interacts with, which is happy, which is a receptor for kinase C. And this is very interesting because we identified some years ago that the parasite expresses a receptor for kinase. So this is an activator of PKC. However, the parasite doesn't have a PKC kinase. I'm not going to go deep into details because we have other works, and here we have Cruz, which was a PhD student from our laboratory. She's going to present her work on Friday. She is working on the Ministry of Health. I'm very happy to see her. And she was one of the people that worked with Haki and RACK1. And together with Satorello, they showed that Haki can inhibit IP3 cells in mammals. But this is a long story, and what I wanted to present to you is the third part of the work that we have been doing, which is related to the membrane receptors, which are GPCR. So once again, if we take a look at the genomes and look for receptors of membrane, we won't be able to find them. So these are receptors that are very well known. They modulate different processes such as depression, diabetes. So they're not found in the genome. So many other labs have been showing this capacity of the parasite to interact with the microenvironment. And it shows that the existence of these receptors is critical in a situation, because these GPCRs, or serpentine receptors known as VCRs, so we have in the membrane, they remain in the membrane, and these are proteins that are responsible for transduction of signals and promote a cascade of events, and so they are responsible for filling different enzymes and hormones and other substances. In the case of the Plasmodium, as we didn't have these receptors identified, so we went to look for different membranes, several different transmembranes. So these are the 4 receptors we're going to talk about. ICR1, remembering that ICR1, ICRT10, ICR25, and beginning from the last, ICR25. And just to remind you that it corresponds to 40% of the target of all medications that we can find on the shelves. So as I said before, have many diseases that use this medication, IPCR. So this is a new target, we believe. So let's talk about this GPCR 25 and we published it some years ago. And what we saw is that first I'm going to talk about a work that a person from Pasteur, he made an interesting work. So he was trying to measure the potassium in the cell and outside the cell. So he could see that there was an increase on the concentration of calcium in oxycytosis of different proteins and others involved in the invasion of the parasite. So what we did is we repeated this experiment with Falciparum plasmodium, and we really saw that they increase calcium in the presence of this high to low concentration, and it can be blocked in the presence of inhibitors of phospholipases C. So just to understand better about this receptor was generated, and so we generated a place for this receptor and this knockout of the receptor. So when it's submitted to the same conditions, there is no increase in calcium, as we can see here on the right. Well, so I won't have a long time to show you all of the details of this work, but it's a very interesting work because this receptor that is in the membrane is a sensor of the difference of the concentration of calcium, and it activates the calcium when it's put into this situation. And so the place of the receptor is more susceptible to different drugs, especially chloroquine, hyperkine, and stress. So once again, there is probably a connection between the digestive vacuole, which is the place where the calcium is deposited, and the signaling of calcium. So these are evidences that we gathered throughout the work. So I'm going to talk a little bit about this last topic, which is Brecht's studies using another system. So using parasites, knockout of parasites, and now we are going to show you how the receptors of parasites can be optimized and transferred to mammal cells. So what is the advantage of doing that? The advantage is that you can have a more robust system, very well known, to try and understand the physiology of this receptor that we might think can be a target for new medication. So just to contextualize, what is the BRET? It's a strange name, but it's the meeting of two molecules. So there's one molecule that wants to donate energy, the other one wants to receive it. So this meeting of proteins that can do this transaction is called a BRET. Transfer of energy, and it's the result. In general, the target is, the receptor is fluorescent. So what we do is we get these receptors and we fusion them with different molecules, which can be these markers, luminescent and fluorescent, and we try to understand if there is a transfer of energy between them and if there is an interaction. So what this image shows is that these markers show just for ICR1 and ISR10. On the first line there's the 1, and on the second line there's the 10. And with the sequencing of DNA there, it appears the receptor appears in these cells. So we can try and make some questions, which can be interesting for us to study. And this new methodology can be used for any kind of model. So if you're interested in trying to understand the fusion of proteins, you can work with different markers, and you can complement it with another protein, and if they interact, there is going to be breadth. So when we do that, then you will see if they're interacting. You can see that they are interacting. There is an increase of this interaction on this graph on the right. And if the same experiment is made for 1 and there is no increase, so we believe that there is an increase in the presence of ICR10, so it's probably interacting and it's acting as a chaperone for this expression.
We can ask ourselves what the state of association of this molecule is to the membrane. Because normally the receptor is one molecule only, but it could be functionally a type of dimerase. So this is very common. In this case, we would like to know if this happened in the parasite receptors. So SR1, SR10, we had this construction of this small bit and large bit to check what happened when we kept the concentration of SR1 large bit and raise the concentration of SR1 and SR10 in this graph here, and we verified that there was no considerable augmentation in this part. This is not even homodimerase or heterodimerase. But the same didn't happen when we had the same experiment with SR10. So as you can see here in orange, there is an interaction when we add the large bit in SR10. There's an interaction between the two molecules and the receptors that have the dimers in the membrane. This is a classic behavior of receptor and interaction. So this next experiment, we had the goal to basically confirm this result, and now using the molecules and look in YFP, and in this case there is no formation or hetero, but in SR10 we are able to form with their own molecule. Now, in these last minutes that I have, I will talk about the last receptor, which is the parasite receptor that uses the same methodology for the heterologous system. And this work was also done in collaboration with Michel Devier in the University of Montreal and Pedro Scapelli. Well, again, now when this receptor was transfected to the HEC cells, Miriam and Alexandre performed a screening to see if there was any molecule that could elevate the calcium concentration. But they found out that the thrombine was able to raise the calcium concentration in this transcripted cell. But it's very interesting once we understand that we have adherence. And what Pedro Scapelli did was he repeated the results, Miriam's results, using another marker that was, he verified that in the presence of the receptor, when they were transfected, they had a raise of intracellular calcium in the presence of thrombine. And now, the next question was, how could we translate this into signaling in downstream, as for example, the activation of PKC or the DART activation? For that, Pedro used a sensor that is able to, when it's phosphorylized, we changed this conformation and approximated these two molecules. And what he's going to measure is Brett in this situation. So here we show this work that thrombin is able to stimulate the deacylglycerol, and PKC in blue showing in this graph to the left the DAG formation and in thrombin presence, and the activation of PKC and in the presence of thrombin in the graph here to your right. Well, and then we were very excited thinking that this was a receptor for thrombin, which would be very interesting to identify. So let's have an experience, a controlled experience, which is to transfect these cells to perform the transfection of this receptor, which connects thrombin to a cell that is for the thrombin receptor, because the host cell also has this receptor. But you have heard that we've used a lot for thrombosis and the medication directed to the PAHO receptor. So for our disappointment, when we use this knockout, the cell knockout that does not express receptor, a mammal receptor, we saw that the difference between MOC and SR12 in the calcium was not present to your right, as shown in the presence of thrombin. So Pedro saw that other receptors also had this property with SR12, for instance, the muscarinic receptor, as showing that they can have a chaperone role of other receptors as thrombin and the muscarinic receptor, so that the receptors work better. However, this behavior of chaperone for receptors but this behavior is interesting. Lastly, and they understood how the cellular distribution was, and it connects with many intracellular markers with the plasmatic membrane, and up there in 7, it shows the receptors that are not completely in the membrane, and part of it are on the membrane. This one is in blue, and big part of it are in other regions, the subcellular regions in the parasite. Well, in my 2 last minutes, I really hope that I showed you and I've convinced you that the parasite is able, even if it's inside a cell, they're able to utilize the signaling, the phospholipase, using calcium as showed in different processes that the parasite executes, that MDR can be a P3 receptor, and we are planning to show that it can also work as a calcium channel. And the genome of the Plasmodium has these 4 candidates for the receptor, and that we took notes now in the GPCR. And SR1 and SR10 can be transported to a mammal cell as an experiment of heterologous prospection. And with that, we know the permit screening and know with the state and with the thrombin receptor and with the application of FKC and the calcium. So this work that I showed you would be impossible to perform if it wasn't for all of these people who were in the lab. Some of them are still in the lab, and these were extremely dedicated people. And more than this, I can't even say a lot because it really touches me to be very lucky to work with people who are so wonderful and that took this work forward. Okay, something that I'm very proud of is to see that the majority of them is way better than myself. They are working around Brazil, outside Brazil, in companies. We have Laura, who's going to be here in the second column, and she's going to be talking on Friday, and she's working in the ministry. We are very thankful for the amount of collaboration that we have and who participate actively in these works. And we have to mention and appreciate the financing, the CNPq, CAPES, NIH, and FAPESP, and to, well, as I said, I won't be able to mention name by name, but these are people who are very special. And more than this, it was a great pleasure to work with all of them. Thank you so much. I hope I convinced you about the Plasmodium, that they understand everything around them. I really appreciate Celia and the audience, and I hope that we've seen a little bit of another side of the Plasmodium, and it's a mini conference. I'm sorry, we cannot have questions here, but as soon as she gets down the stage, you can ask her a question. Thank you. Thank you for your brilliant presentation. Now continuing, we'll start the mini conference called Malaria Mosquitoes. For these works, we will invite the Department of Health researcher, Wadi Wolf, Center USA, GenCom. Good afternoon. Thank you for being here after a long day, but fabulous here in Belém. I'm going to be doing a brief introduction, but Dr. Toby Lemon, which will talk to you. And he has more than 20 years of experience in populational genetics, ecology, and mosquito behavior of African malaria mosquito, the famous and well-known Anopheles gambling. When I knew him initially, he was a postdoc in CC, and he investigated the genetic flow of isolation regenerative for populations among species. He found some new things and some very important discoveries. His research is concentrated in factors that require the susceptibility of the mosquitoes in the pathogens. And in the last 10 years, he has on board the paradox of the malaria in the dry season, exploring the usage and migration of long distance of the vectors and arid environments. And very important for people in Africa. And before he went to the yacht, he studied the behavior of nematodes and parasites and the populational biology of ectoparasites. And tonight he's going to talk about the invasive Anopheles stevensii, which is one of the most important now for Africa and the world. We'll provoke some discussions. I really hope that you have questions at the end, because we should discuss this very important theme. Thank you.
Malaria, dengue in urban areas, and other threats. And I think that sharing more of these lessons that we have each learned could change our action plans. So I will be talking today about a new threat in Africa that is urban malaria. This is something new. The vectors of malaria in Africa are well known for their efficiency. However, they are primarily rural. Half of the population is found in urban area and therefore is partly protected from malaria, no more. So what is the reason for this change? About a decade ago, the urban Asian mosquito, Anopheles stevensii, has landed on the continent. And since then, it has invaded and spread rapidly across the continent. Today we will be describing some of its basic characteristics and discuss how it spread and why is it important. Why is it important even to you here? Because should you be worried that it is already now found maybe in some port in Rio de Janeiro? So this is a new concern, and the mechanism of spread is relevant to your outlook about your malaria threats here, but also it's important to understand how it moves over land, which could be quite different than its movement overseas. So many of these insects exhibit multiple modalities of spread. We will touch on this. And this is, of course, very important to elimination plan. And maybe some of your problems about what was called earlier about residual transmission. Malaria was very successfully depressed, but then could not be handled in a particular state. So the question is, can we ignore what's happened in neighboring states, and to what extent mosquito movement, in addition to what we are aware of, people movement, could be important in maintaining this residual transmission. So if we don't understand the sources of reintroduction, we will not be able to reach elimination. And finally, we will try to distill this to a draft ideas of action plan, which I hope we will continue to discuss over dinner and over the next several days, where I believe that your experience could be extremely valuable to us, and maybe we could even put some more concrete plans beyond just exchanging ideas. So everything, I think, is welcome. So here I show the current distribution of Anopheles stevensii in Africa as of 2023. It landed in Djibouti in 2012, and in just 9 years has moved to West Africa, Ghana, and Nigeria. So this is a very remarkable spread across very large distance. As we will see, this is a species that is very good vector of both falciparum and vivax malaria, and it is as good in urban as in rural transmission areas. It is unique among African malaria vectors because it can breed successfully in containers, essentially in almost every body of water that is not overly polluted by organic matter, and this allows it to persist even during dry seasons in settings where most other malaria vectors seem to diminish or almost vanish. So it is also difficult to survey and to control because it is spending much of the time outside, it feeds outside, and it feeds on animals as well as on people. So the contact that, the tight intimacy that most African malaria vectors have with human dwellings and with humans, which is an opportunity for interception and control, is much more difficult to achieve with this vector. And at the end, it's also found to be quite resistant to all the major groups of insecticides that are currently in use in Africa. So this results in a really new game changer. And what I'm going to show you here is what happened in Djibouti city after its arrival. If you notice, don't know where, oh yeah, it's here. If you notice, in the first 3 years, that is before its landing, the number of cases in Djibouti was about 500. It was near elimination. But after that, it skyrocketed to 75,000. This means that it's about 150-fold increase over a span of just less than a decade. This is a very frightening specter because it is not only Djibouti that we will be addressing. It is also shown similar rapid caseload in two other cities in Ethiopia. So this is a huge concern because this is just the beginning, and very early on we are seeing a huge impact. Now, if we are doing some exercise and we are trying to conservatively estimate what would happen when it will reach about half of the cities in Africa, maybe it's 10 years because it spread so fast, maybe it's 20. But in this exercise, which is very crude, but try to be conservative, we are not changing the population size, we are not changing the case fatality rate, but we are just adding the fact that half of the cities in Africa, which means 25% of the African population, is expected to be subjected to only 10-fold increase, not 150, not 30 or 40, but only 10-fold increase. And we are talking about tripling of the burden, both in terms of cases and fatalities, which is unimaginable. It is equivalent to bringing a totally new disease to the continent, which will rank among the top 10. So we can think about urban malaria as a new entity. It's not at all thinking like malaria is usual. It's a totally new creature that is out there. So this is obviously an estimate. It may be true or not. Up to now, what I think I try to do is to convince you that this is an important threat that we cannot say it's just another malaria vector in Africa. This is not another malaria vector. It's a totally game changer. So we are now going to shift gear a little bit and deal with the question of spread and sources, how it came to Africa and how it is spreading in Africa. And to do that, we will contrast it with another friend that most of the people here are familiar with. Even if they don't know, they have certainly experienced it, Aedes albopictus. Both of these vectors have spread from parts of Southeast Asia about the same time, from the 1970s to the 1980s, they started moving. However, we can see that even though they started about the same place and they've started about the same time, they are very different. In the first 2 decades, Aedes albopictus has already reached, and this is a map only showing where it landed initially on a continent. So it landed in South America, in North America, and in Europe in the first 20 years. In the same 20 years, Stephen Vai just glided a little bit to the tips of its already, so very small increment. Go another decade, and this Albopictus is reaching to the other side, to the Pacific side of the US, independent introduction, at least one, if not more. It is also reaching to Africa and to other parts of Europe, independent introductions. If you continue, you could see that during this time where basically it reached to Australia, this is Albopictus, essentially it reached to every continent and to multiple regions within the continent, very distant from each other. Anopheles stevensii just has advanced to the edge, the southern and the western edge of the Arabian Peninsula. And then, by the last, basically, decade that we have on the map, it moved to Africa. It crossed the first barrier of water. So you could immediately see that these are not the same processes. So our expectation that stevensii is a maritime traveler that is similar to Albopictus is not holding very well. Albopictus is moving with huge jumps and leaps because it uses a vehicle that can traverse large distances over a short time. In days or weeks, it covers thousands of kilometers, whether they are water or land. So this is a capacity that stevensii does not share because it is like an amoeba. It is spreading very gradually. So it is self-propelling itself somehow. And the question is, how? At the end of this time, we are talking about a stevensii map here is only what is shown in this square. So vastly different. Now, if we are looking on the mechanism where it could move, at least over land, and you could see how rapidly it moved within the continent, we maybe need to think about a different approach. I'm just not going to go in detail here, but I want to show you about underappreciated movement modality of mosquitoes, that is to fly several hundreds meters above ground and be taken by winds and traverse large distances that we typically are not equipped to know about. So this is a method that we have been using for almost 12 years now in Africa. It is a large helium balloon that is tethered to the ground, and on the rope on the ground we are fixing certain nets. These are standard insect nets smeared with film of insect glue. They are 1 meter by 3 meter each panel, and we typically suspend them between 300 meter and 120 meter above ground. And they are launched during the sunset and retrieved during the sunrise, and when we launch and retrieve, we have a control panel that go to 100 meter and immediately brought down to see what has been coming near the ground. So we could contrast the control and the other one to say what has been collected at altitude. And what you could see that when we are bringing these nets down, they have usually several hundreds of insects. And if we are lucky, there will be more than few mosquitoes on them. Sometimes it could be actually more than 30 mosquitoes per panel, but this is very, very rare. But even finding 1 or 2 has a high significance. So here is a map, is a graph of the species that we have been finding in a collection of 740 mosquitoes that are collected in 5 ecozones in West Africa, but in all ecozones we see this movement. And we can see that these are members of Culex, Cochletedia, Aedes, and Anopheles, among other genera. So this is very mosquito-ish behavior. It's not rare. It's not something that only crazy mosquito do. You could see by the more than 50 species that are listed here and by the membership that this is quite common. We estimated between 1/4 and half of the fauna of culicids in Mali and Ghana are participating in this windborne movement. So the other important thing that I want to highlight is that this could be also important for pathogens. The number in red is the number of arbovirus species that have been linked, not necessarily proven as bona fide vectors, but implicated as likely transmitted by the species there. So there is no reason to think that they are traveling alone, and I'm not going to speak about this today. if you would like, I will talk about it separately. So just to tell you more about these mosquitoes, these are very different composition from those on the ground. We have done a lot of mark release recapture to understand modality of movement in the flight boundary layer, and males are exactly flying the same distances as females. And this is not only our group, but when it comes to high altitude, it's very feminine behavior. Maybe males are afraid of altitudes, maybe they don't see it as a very beneficial, but the result is that it's 6-to-1 or more female to male, and the majority of these females are gravid, semi-gravid, or having, so the percent female is on this axis, and the composition of those species are listed there. That is to say that they are ready to lay eggs whenever they land, and often they are traveling on the monsoon winds, the same winds that are carrying with them rains, so they are likely to come to a pretty favorable location in terms of at least body of water. And human density is pretty good in many of these areas, so it is unlikely that they will be, totally without domestic animals, humans, and the possibly other animals that surround them. So just last thing, what is the epidemiological significance of this number? We could translate the panel density, the number of mosquitoes per panel, to aerial density, and calculate how many mosquitoes will move per season on a 100-kilometer sector. There is evidence that these movements occur in large fronts. The evidence is based on radar studies, not looking on mosquitoes, but these mosquitoes are part of a huge aggregation of insects that do it, many species. Some of them are important for food security. Some of them are important for ecosystem stability. So this is a system that is not only, mosquitoes are less than 2% of what we are collecting. So if we are using the translation, we see that a species that was collected by a single individual, the primary malaria vector Anopheles gambiae, is going to be 80,000 mosquitoes will cross a line of 100 kilometers between 100 and 300 meters above ground, and they may fly higher. And if you think about a more common Anopheles squamosus, which is still far, not very impressive species from the Iodine and the Culex that we have seen in the other thing, this is going to be about 40 million that are going to cross this sector of 100 million. So the low efficiency of the method is hiding the epidemiological, but even low infection rate, even few successful migrants are expected to have important implications for introduction of genes or pathogens, and for reintroduction of pathogens or themselves from area where they were eliminated. I just want to show that based on flight meal studies that mosquitoes have been subjected to, nutritional reserve, and other epidemiological data, mosquitoes are expected to be able to sustain flight for up to 10 hours. Maybe more actually. So this is up to 9 hours, and we could see that if they are flying only 2 hours, they will be somewhere between 30 and 40 kilometers on average, and if they are moving 9 hours, they will be flying closer to 100 and some to 300 kilometers per night. Remember, some nights the winds are much stronger, so much stronger that there are cases of insect blown more than 1,000 a kilometer per single night. So this is now coming back to our Stevens eye. All this suggests that this is a possibility. Could this explain the movement from Asia to Africa? So this is the current map, and what we have done here, there are population of Stevens eyes that have been established, if you remember, this sequential traverse. So around 2000 to 2010, they were already established in the southern and in the western part of the Arabian Peninsula. And this is a simulation based on what is the percentage of cases where a mosquito that's coming from each of these points will end up in Africa. And if they are coming from, say, Yemen, the chance that they are coming is about 12%. So every 10th mosquito at least that is going up around this area is going to end somewhere in Africa, and there are other locations. So the probability of this movement is high, and you may be thinking why it happened only in 2012. So this is another thing that it is good to leave for the dinner. just another important question that I think we could address. So, just to also say that this is not the only mosquito, the only creature that is up there. This is Courtara insularis. It is a leafhopper that is South American. It's known in Brazil, in Argentina, and we found it for the first time 200 meters above ground in Ghana. So it was the first record of this invasive species in Africa. This is not the only interesting part about it, but it was getting some, real curiosity. How come that we found it in the air? So we already know that it can use high altitude movement, but moving through the Atlantic is almost impossible because there is a conversion zone. So the winds are not typically allowing this movement. It's extremely rare event to have a continuous corridor, even if you are capable of, sustaining yourself in the air. So we have been lucky because this species also invaded North America. In 2004, it was first recorded in Florida. And unlike Africa, there have been a lot of reports about the sighting of this Courtara insularis. So from this, we could generate the per annum range expansion rate. So what you could see here, the years of, sorry, wrong one. So you could see here that on average, it is moving about 250 kilometers. There is 1 year where it was actually moving close to 1,000 kilometers. And this was in Houston, Texas, in the largest port in the US. It was intercepted several times, at least 9 times in ports, as ships, were inspected by different agents. And it was also found on 2 trucks that demonstrated that this species is using multiple modalities. So the main lesson here that inland, this curve is suggesting self-propelled primarily. So the reason that it is, because if it was using trucks or using airplanes or using primarily the other, it will cross all these areas. But because on overland in the US, it was only regularly expanding its range in about 250 kilometers, it is much more explainable, not proven, but explained by self-propelled movement using wind-borne movement. And it's not the only one, so it could also generate some big leaps. So this is a case that I want also to think about this like Stephen's eye. We do not know how Stephen's eye move. All that I showed before is a speculation. So far, it was not successfully being intercepted in any ports to the best of my knowledge, and I tried to follow it up. If other people know to the different, so finding it on board of ships or on board of vehicles is not yet been demonstrated, but it's likely that it will be. However, we still think that based on its movement pattern and its arrival to some very remote area and distant, we suspect that air wind-borne movement at altitude is likely an important source, and this could also be important in predicting its future steps and in dealing with reintroduction if we will consider elimination. So this is what we have been. 10 minutes, perfect. Yeah, and I'll just, don't worry, I will not extend over the 10 minutes, even if I need, I will just cut and we will be eating. So you will have to be well cared for. Don't worry about the dinner. So, in Mali, we have started a surveillance to find Anopheles Stephen's eye about 2 years ago. And because we know that we are often wrong, we concentrated immediately around the airport. The airport is the focus, probably about 60% of the effort we are trying to invest there because it's very likely and very dangerous spot of arrival. And then we also are looking in near roads where most of the trucks are being stopped by customs, sometimes held for a long time. 2 weeks, sometimes even more than that. So we are looking in a transport route that coming from Burkina Faso, from Ivory Coast, and from Senegal a little bit. So we are, so far, have not been able to find it, but during this time we asked in Mali who is, going to take care of it if it's being found, because we are not typically doing any control in the group. And we were actually surprised to find that nobody is making concrete plans yet to address it. So there is nobody is preparing for its arrival, and actually there is also no other agencies that are searching for it. So this is an important aspect, and I think what we are doing once we found it, and I think it's only a question of time, not if, I think that it is really critical that we will be prepared. And this is basically the last part of the talk. We talked about movement, we talked about the importance, and that is, I think, what we can do to be better prepared for that, where it is and where it is not, because this is all one area where it is likely to be impacting. So invasive biology had thousands of examples over the past 50 years or so where the field has really crystallized and developed. And they are considering this the invasive curve because it is show what is the effect of time on the area infested and in the prospects to eliminate. So it shows that typically detection of a new invasive species is occurring quite a while after introduction, and this is the best time where even with lousy methods you have excellent chances to eliminate. And this become less and less green, and by the time that it moved to the orange, it become extremely difficult task to eliminate it. So you only hope for actually management or control. The question is where we are with respect to Anopheles stevensii. Before that, I want to highlight only 2 points with respect to the difference between successful and non-successful elimination campaigns. And I will actually just deal with the last 2. So I want to sharpen this point that early and decisive response, even if messy, using non-perfect techniques, but still bringing a very sincere effort to eliminate this population, is one of the critical differences, which is contrasted with monitoring to wait until we know everything and until we develop the best method to deal with it. Because then we are certainly going to be in the red, which will be almost impossible to address with most techniques. The other thing is the minimization of reintroduction. Part of it has to do with the fact that you do it early on, before there are many populations that could exchange migrants. So they are reinforcing each other. I think that there are other important quick criteria that we could consider, but I really want to highlight these 2. Now, we are not sure where, maybe we already missed the point here, but I think that there is good evidence that we have not. One of the hallmarks of new invasive species that are not well adapted to their new environment, that populations seem to be unstable and often crash. This has been seen, for example, the population in Ghana and in Nigeria have been spotted and been confirmed, and then when surveillance has expanded, as far as I know so far, have not been found. Also in Kenya, there were some populations that established themselves for over a year, and then they vanished by themselves from those locations. Recently, I heard that they have popped out in additional locations. So they are still in Kenya, but some of the sites where they were tracked initially have, those populations, to the best of my knowledge, have collapsed. So this is a good indication that the species is facing some challenge in this new environment. We don't know yet what is their nature. It might be that this is adding to the optimism that we are still closer to somewhere between the greenish to the early orangish phase. So I think that, again, the message that I mentioned here, that if we are waiting for the perfect information, the perfect solution, we are essentially inviting it to reside, to be in part of the landscape of disease in Africa. So we are actually looking on some of the most first examples of where invasive species, not natural not native species or naturalized species were successfully eliminated. And there are many such examples. Obviously, here in Brazil, the elimination of Anopheles arabiensis, also referred in the past as Anopheles gambiae, served as an incredible example because it was using very crude methodology, yet it brought a complete annihilation of these invasive species. The same species, Anopheles arabiensis, has invaded parts of Egypt and was also successfully eliminated using those very meager set of tools in the toolbox. There are more examples, but I'm not going to mention them. And then I want to highlight that even though Anopheles stevensii is the invasive that we talk about, he is not the only invasive. He is just one of the last impactful invasive, and there are many others. So this list can grow way outside the slide. This means that we are not prepared. We were not prepared with early examples. Aedes aegypti for sure, no blame. Aedes albopictus, maybe we could be slightly better prepared. In some location at least, we were not. But can we allow ourselves to continue be unprepared at all for all these invasive threats? And basically just wait for somebody else to do the role. Maybe we should take a more active position. So I think that we need to address this case, and there are some important opportunities, not for elimination. I'm not proposing Egyptian elimination from Africa, so don't have confusion about that. But I think that addressing dengue and control of Aegypti can train entomologists in Africa to address stevensii whenever it is popping in their area. So the idea that even if they are practicing, so to speak, on Aegypti, they will improve the situation with Aegypti, but at the same time, they will be a mobilized force that could then launch on the first records of reports of stevensii invading their countries. So what is this kind of a plan? Who could lead it? Currently, there is a very exciting, young, vibrant, highly professional group of medical entomologists and other professionals in Africa called the Pan-African Mosquito Control Association. It's not only medical entomologists. And they are well connected to PMI, to WHO, to IVCC, many agencies, and I don't want to emphasize only those that deal with insecticides. I don't think this would be the main tool here. It may be important, but not the main. But the key issue that they are waiting for such opportunity to prove themselves, and they have a lot to bring on that. I have a good, at least hunch, that they could be some of the main leaders of this. Also, we could bring people that have experience of Anopheles stevensii in Iran, in Pakistan, in India, and learn from them. At the same time, we have to reach out to people in Brazil and other places that dealt with urban vectors and try to deal with the different strategies, because in Africa there is essentially no preparation. People, I think, have almost no clue, and I am among them, in dealing with urban threats of this nature. So I think that there are people that could create as a basic program that will be able to implement immediately, not sequentially, immediately, the issue of surveillance, the issue of training and capacity, training and implementation of different control regimes. And this is going to be led by assessment and reassessment to find what combination of tools are most effective to what settings. So, because I think that this could be still addressing relatively small areas where population have established. I think that the effect of this would be very valuable, and of course to open everything to a discussion with regulatory agencies. So just to understand that the toolbox that is currently available is much larger than we had during the 40s, and I don't have time here to enumerate that, but if you are just scanning that, you could see that there are many elements that are very different, and we could imagine that ivermectin treatment, for example, at some particular time points in humans and in animals can be very important element to suppress population and suppress transmission. And this is totally new, and there are a number of other new tools that are awaiting their first trials. So, what I want, just one thing going back, I'm trying to be bold here, and I'm trying to suggest that given that this is not the last rate, given that it is happening, the idea to create a unit that could generate actually assessment of new invasions of disease vectors, not only mosquitoes, but advocate, coordinate, train, implement, and then reassess with red lines. The idea is that we are not committed for a fight forever. The fight has to be cost effective. These red lines, if they are not being met, and if the reason is not technical, that could be easily fine-tuned, it means that the operation should change. So I want to thank you for your attention and suggest that we will continue this discussion and hopefully could help each other in these challenges. Thank you very much for your attention.
Because everybody's starving and you're all tired. But muito obrigada para sua atenção e eu espero que poderemos seguir falando sobre esse tema tão importante a todos nós outros.
This is such an important theme, especially not only people in Africa but also here. Thank you. Thank you for your brilliant participation. We reached the end of our day, and at this point, we finished the activities and this first day of the 17th RNPM. And then I remind you that the programmation continues until Saturday, November 9th. Have a great evening, and a final advice about the dinner. We will have an opening dinner for this first day. We are all invited to participate from 7:30, the same place where we are having lunch and the breaks. For accessing dinner, you must have access, and if you still don't have it, please go there for the accreditation to access the dinner. We are all invited from 7:30 on. Have you a great evening. See you tomorrow. Thank you.